Enthusiasm is pouring out of you guys. All right. Well, I'm Susan Averett, and I am the state chapter president for the Arkansas chapter of the American Academy of Pediatrics. And I'm very excited to kick off this conference today. It has been a few years since we've been able to gather in person. Last year we did have a virtual conference, but this year we got to see some faces, see how tall people really are. When you've had a lot of meetings, I'm like, you're shorter than I thought. And your chin looks different if I've been in person and you've been wearing a mask. But we've got a really great program. Our team has worked really hard to put together some excellent topics for us to go through and discuss in the next 2 days. I really want to thank our educational committee for all their input and our stellar team of executive director and her support team, Anna Strong, because they've worked really hard on this. So hopefully everybody will learn a lot. And I want to thank our vendors and the other people who have worked together to get this off the ground. And I just wanted to welcome you, and I look forward to meeting everyone throughout the weekend. Anna.
Thanks, Dr. Averett. And let's give Dr. Averett a hand for leading us through a really exciting last couple of years. So I do want to give a big shout out to our education committee. This group has met dozens of times, I feel like, at this point, to try to put this conference together, coming up with ideas and helping to prioritize and manage our vendors and budget and all of the things. And so let's just give our committee a big round of applause for helping make this happen. And then, like Dr. Averett mentioned, we do this year for the first time have sponsors for our conference. And so we want to thank our gold sponsors, Abbott Nutrition, which is supported, made possible in part by an AAP educational grant supported by Abbott Nutrition, which is a big supporter of the AAP at the national level. The Delta Dental of Arkansas Foundation, which has provided us a 2-year grant to really help us build the foundation for an annual conference. They have been amazing and wonderful at helping us to have some time paid for our staff and some of the food and a couple other things covered that have helped us really get this off the ground. And then this year we're welcoming for the first time Arkansas Blue Cross Blue Shield as a corporate sponsor. And our bronze sponsors, Aptus Financial, Arkansas Children's, Delta Dental, and SHARE, the State Health Alliance for Records Exchange, which is our state's health information exchange. So we are glad to have all these folks at the table helping support our conference. And we know that they really support both the health and well-being of kids, as well as the health and well-being of you all, our pediatricians in this room. And then you've already had a little bit of a chance to mingle with our vendors who are outside today. We have 18 folks spread around the room out there. Please go visit them. They have been kind enough to bring their expertise, their resources, and all of the great things that they do to you today. We hope you can make some really helpful and useful connections with them out there and learn a little bit from them and help them learn what pediatricians' needs are. And then I will just also mention, if you are a lapsed member, or if you maybe haven't made the choice yet to join our chapter, we would love for you to join our chapter. And I will tell y'all that Workday has done a number on our memberships at the UAMS transition to Workday. We had a big old dip the last couple months as that happened, but we are ready to hopefully get past that. So if you all need a QR code, there is a state chapter membership, and you can do national and state on that side together. If you, I'm reading that right. Yeah. On the far, that's to your right, is the national membership, where you can join the national organization and the state chapter together. And I will just tell y'all, we really depend on those memberships. Those pay for our time at the Arkansas State Capitol. Those pay for our time in doing membership focused events and helping to cover some of the basics that we do. Almost everything else we do is grant funded. This conference is still at about a break-even point, so we are not making a lot of money off of it, but we hope to grow it over the years. So that membership revenue is super important for us, and being able to do some of the core functions and advocating on your behalf at state agencies, with legislature, the state legislature, and at the federal level as well. So thank y'all for all your support. And also we have something very new this year, and I don't know that I've seen Dr. Rogers get here quite yet, which is a-okay, but I'll just jump in here. We have a related foundation for the Arkansas chapter of the AAP. It's called the Arkansas chapter of the AAP Foundation. And it is a 501c3, just like many other nonprofit organizations that raises money to support the work of the chapter. And so we have just established a link where you all can go on via PayPal and make a donation. Just if y'all have ever done that for a campaign or for another nonprofit, it's just the same. It's really easy. And we put that code up there. We'll have it up here a couple more times throughout the weekend. If you have enjoyed what you're doing and feel like you want to put a little extra support, even $10, $20 would be wonderful to help support the work that we do. And again, that is a new option that is through our foundation. We're really trying to grow the support beyond just your membership dues to our chapter. And then we will just mark a couple things that are coming up for you to have on your radar. We are doing an LGBTQ plus youth health symposium Friday, November 4th and Saturday, November 5th. And that is funded through a grant that is from the Arkansas Community Foundation and funded through some of the Walton family members in Arkansas. And we've been very thankful to have received that grant and are really excited to be working with our practices across the state to help educate, inform, and help to do some practice transformation work in the space of welcoming environments for LGBTQ plus youth in the state. And then our 2023 conference, if you're the kind who likes to plan those schedules out, we are going to try to do this the same weekend next year, August 25th and August 26th in 2023. So you can go ahead and put that in your calendar now. And I will just cover a couple quick logistics and to-dos real quick. So UAMS is currently requiring face masks unless you are eating or drinking or if you're at a podium. And we do have a lot of exits in this building, which I feel like is the very trendy emergency response thing to do. But you have exits at both ends and both sides of the building. So if you all need to get out of here quickly, that is how you do that. Our restrooms are both upstairs and downstairs. The downstairs ones are right out there across the hall from us. There is a water bottle filling station too, kind of near the doors that most of you came in up near the front. And then our meals and snacks and drinks will all be served upstairs. There's an elevator or stairs that can get you there. I think most of you have been able to take advantage of the food options, which was great. And thanks to catering to you for those. And then lastly, Wi-Fi is in your program, but it's UAMS guest and it shouldn't, you have to put in your email address, but it's not a login. So you should be able to get onto Wi-Fi UAMS guest. And then I promise we're almost done with this part. But we'd love for you to tag us on social media. If you are on Facebook, Instagram, or Twitter, we have a couple hashtags you can choose from. One's a hashtag ARAAPConf, and the other one is hashtag our building blocks. And you can use those and put them into some posts about what's happening and what you're doing. And those are our handles. If you aren't following us yet, please go do that. And then very lastly, I'll just briefly cover our schedule for today. We are during the welcome right now. We will launch very shortly into an address that the AAP president, the national AAP president, Dr. Szilagyi, recorded for us. And you will hear from her for about 15 minutes about what's happening at the national level with the AAP. And then we will really bring it home and talk with lots of awesome pediatricians and other experts here in Arkansas about what is going on with kids' health. So we'll start with Dr. Karen Farst. We'll have some breaks where we would love and encourage you to visit our vendors and take a break, grab a snack, grab a water, etc. Step outside, take your mask off. And then we'll have a really great set of breakout sessions. We will come back and have the state of children's oral health in Arkansas with Dr. Natalie Burr and Sarah Crawford. And then Dr. Gwen White will wrap us up for the day with our historical and contemporary racism in children's healthcare in Arkansas. And so I'm really just thrilled about the panel we have today. We will have 3 resident poster presentations today, so we're very excited about those. We are not quite sure where those are going to be because we have lost the poster board things that were here a few weeks ago, but they will be somewhere and you will find those on the way. And then if you would like to join us at Hill Station this evening, we will have an outdoor gathering there where we will have some snacks and beverages that people are welcome to partake in and have a little time just for fellowship and gathering. So Does anybody have any questions? If you want to ask a question in here, there is a little button that looks like kind of a person speaking on the mics that are kind of between every other seat. You can push the little speaking person and it will actually like apparently queue you up in order and then like let you know when it's your turn to talk. So I don't know, that seems very fancy to me, but we have not tried that out yet. So I can't wait. I hope y'all have lots of good questions. Yeah, any other questions today? Okay. Well, thank you all again for being here. We're going to go ahead and get started. And thanks to all those who have supported the work that we do here. And let's go ahead and hear from Dr. Salaji. And do you want to do a quick introduction of her video?
Well, I'll just.
Yeah, go ahead.
I just wanted to say that as in this leadership role, I've gotten the opportunity to see just how far and wide the influence of the national AAP, as well as our state chapter. We have a lot of local and state influence, but nationally, the AAP has really had a lot of positive influence with advocacy and leadership. And so Dr. Salaji is our current AAP president, and she has had lots of years of being in advocacy and leadership and just a lot of influence. It's just really impressive to see the influence of the AAP on the national level. So it's exciting to hear from her now. Let's just see what happens.
Hello, everyone. What a treat to be a part of your meeting. I understand that this is your first in-person conference in a while, and I wish I could be with you to celebrate your chapter's tremendous growth and success, and your important work on integrated behavioral health, WIC, and vaccines. But I do thank you for including me and for everything that you do for the children of Arkansas. As a foster care physician, I have nothing to disclose beyond receiving some small royalties for some work that I've done, but I do want to disclose my gratitude to each of you. These last couple of years have brought an unpredictable series of events: a pandemic, isolation, loss, uncertainty, racial strife, and gun violence. There has even been anger directed at pediatricians and other healthcare workers. And on some days, just having the will to persevere has been a victory. These hardships and how the AAP can help were discussed at length at our recent AAP Leadership Conference, where our top resolution this year, voted in by the leaders of our districts, chapters, and committees, councils, and sections, is supporting pediatrician advocates who are experiencing adversity. I really cannot overstate how grateful I am for your courage, your compassion, and dedication throughout the pandemic and the heartbreaks and hardships it has engendered and that have followed. Despite the immense burdens that you have borne in your hospitals, clinics, and practices, you've continued to advance pediatric medicine and protecting care for the children and families of Arkansas. As pediatricians, we are facing a lot of big challenges, and we are doing it together as we explore how we can find gains in our losses and take the lessons learned from our national traumas to heal, protect, and promote the health of a generation of children at risk. We're going to continue at the AAP to pursue our interrelated child health priorities for the upcoming year: responding to the COVID-19 pandemic, promoting vaccination and vaccine confidence, advancing health equity, and addressing the pediatric mental health crisis. The AAP has been a clear, persuasive voice for infants, children, and youth throughout the pandemic, and we continue to tell their story through careful data collection. This work has been featured in nearly every major media outlet, and our nation's pediatricians, policymakers, and public health experts rely on our weekly reports of child COVID cases, hospitalizations, and vaccination rates. We are pushing back on the myth that COVID-19 is not a disease that affects children. We're also all aware that there was an epidemic of youth depression, anxiety, and suicidality even before the pandemic. In 2018, suicide became the second leading cause of death among youth 10 to 24 years of age, accounting for more pediatric deaths than the other 20 leading medical causes combined. During the pandemic, rates of depression, anxiety, and suicidality climbed even further. And even as pediatric emergency departments across the country experienced a significant drop in patient volume, they experienced a disproportionate rise in pediatric visits related to mental health. To help clinicians support youth at risk for suicide, the AAP and the American Foundation for Suicide Prevention worked with the National Institutes of Mental Health to create the Blueprint for Youth Suicide Prevention. This is our nation's first major interdisciplinary effort to infuse suicide risk-reducing strategies into pediatric care and community settings. It lays out policy recommendations to address upstream risk and protective factors, and it provides ways to support youth at the immediate risk of suicide. The Blueprint is designed for anyone who interacts with youth, whether that's in schools, the community, faith-based, or health organizations. It's a fantastic resource, and I urge you to take a look at it on aap.org. Now more than ever, families need access to pediatric mental health screening, diagnostics, and an array of evidence-based therapeutic services and treatment to appropriately address youth mental health needs. Children are not little adults, and nowhere is this more evident than in mental and behavioral health. The brains of infants, children, and adolescents are rapidly developing in response to their environments. They're not fully formed. A significant portion of mental health and behavioral problems in children reflect the accumulated effects of trauma and adversity on their developing brains. And the AAP is responding with a comprehensive strategy and set of initiatives to support healthy mental and emotional development. We call this Upraising Healthy Children. We introduced this last month at our corporate summit for AAP donors. It's designed to provide pediatricians with training and education to provide trauma and resilience-informed relational care throughout the ages and stages of the developing brain. This is to occur in the medical home and in all pediatric settings. Beyond our strategic child health priorities, we continue our core work in setting policy and guidelines for our profession. In the last 12 months, we have published 54 policies, technical reports, and clinical guidelines. As president, I believe I have read every single one. Most recently, we released cornerstone policies on breastfeeding and reducing infant deaths in the sleep environment. And I can tell you more are on the way. Our policy is crucial because it is the foundation of our advocacy work. It summarizes the evidence, expert opinion, and best practices as we advocate for core issues, such as keeping babies safe in their cribs. In May, President Biden signed the Safe Sleep for Babies Act, outlawing the manufacture and sale of crib bumpers and certain inclined infant sleepers. So congratulations to all the pediatricians and other advocates who worked tirelessly for many years to protect infants from dangerous products in their sleep environments. Another challenge we find ourselves up against is battling the infodemic of false and misleading information. The words disinformation and misinformation are merely one letter apart, but behind that one letter hides the critical distinction between them: intent. Misinformation is just false information. Disinformation refers to false information that is deliberately spread to manipulate the narrative. But whether it's mis or disinformation, or whether you're in primary or subspecialty care or in the operating room, harsh political debates questioning the evidence for masking or COVID vaccines leads to uncertainty and fear about the medicine that we all practice. At the AAP, we are advocating for COVID-19 mitigations and vaccine promotion based on evidence for the benefit of public health, and education to counter the mis and disinformation that erodes the trust in science. This work will take a long time and is going to need many voices. And we will continue to work with the administration, other medical societies, and anyone else to educate the public. Here's a screenshot of me at a June HHS multicultural media briefing on the COVID vaccine for children under 5. I'm the one who's not retiring imminently. We've partnered with YouTube on a very successful series of nearly 50 videos. The advantage of partnering with YouTube is that they bump us up in the algorithm because of that partnership. So our videos about how vaccines work and why they're safe have been viewed thousands and thousands of times, reaching new audiences. This partnership is going to continue because we have a new contract that we just signed for 75 videos over the next 18 months. And the first batch will be 20 new videos on mental health. These partnerships are essential to amplifying our voice and getting good information to where people, especially our youth, go to look for it. As we work to educate youth, families, and the general public, we've also remained focused on the economics and the business of pediatrics. Valuing children has to include valuing the doctors who care for them. One lasting lesson of COVID is that the current healthcare financing system does not work for children or their doctors. It does not pay for the care we provide and often does not pay for the care that an individual child needs. The AAP is working toward a better service delivery model and payment system that will include value-based models, provider incentives, and standardized benefits that families can afford. We're leading the way to actualize the promise of high-quality, comprehensive, coordinated, team-based care for every child. We're working for care that will better support the pediatric workforce and their challenges, address healthcare inequities, encourage innovation and communication, and expand collaborations with public health and other stakeholders. Our advocacy has been unrelenting. Our AAP members have been steadfast in speaking up for children within their clinics, their communities, and with state and federal legislators and with the White House, even when the conversations are hard and the environment is hostile. Let me just say, from one advocate to another, what you're doing matters. It matters to children, it matters to families, and it matters to communities. And we at the AAP plan to keep doing it, no matter the obstacles, because this is what our mission on behalf of children demands of us. And of course, the closer we get to the midterms, the harder it's going to be to get legislation passed, which is why it was so important that thanks to advocacy from the AAP and other major health organizations, the Department of Health and Human Services extended the COVID-19 public health emergency into October. This is not an abstract thing. It's an entree to social services, vaccine, telehealth, and many other aspects of care. The PHE keeps many health benefits in place and affords key flexibilities to providers and states. Take Medicaid and CHIP, for example. This graph shows a pivot point, how the number of children enrolled in Medicaid and CHIP rose when the public health emergency was declared. The increase in coverage is laudable. It's up 14%. But the graph also drives home the point that 53% of children are now covered by Medicaid and CHIP, making it the primary source of healthcare coverage for children in the U.S. What that means is that 53% of children are eligible because they are poor or near poor. The policy implications of this number of children living in poverty are inescapable. The ramifications for those of us who care for children are also inescapable. Poverty is not good for children, and the low payment for Medicaid and CHIP is not good for us. The policy implications of the large numbers of children exposed to violence is also compelling. Violence is far too prevalent in our society, whether it be interpersonal violence, violence between caregivers, child abuse, forced immigration, bullying, or the epidemic of gun violence. Children and families live with far too much adversity, fear, and conflict, and have been exposed to too much malice, isolation, and hatred. Our political climate thrives on conflict and confrontation, instead of on compromise, cooperation, and collaboration. Yet these are the very things that make for a stable society and are protective of our children and promote their well-being. The heated rhetoric and violence that emanate from conflict are not good for children. They undermine their sense of security and safety. They are, in fact, not good for any of us. The recent tragedies in Uvalde, Texas, Buffalo, New York, and Highland, Illinois, were cruel and horrific, but they are just part of a larger list of tragedies that occur every day in our cities all over the country, large and small. We must look more deeply at the communities and environments our children are growing up in, including the social media climate. And we have to continue to be the voice of reason, compassion, and kindness that is rooted in science and evidence. We advocated hard for the recent gun legislation, and this is an important, although an incomplete law. It's the first time in almost 30 years that Congress has passed major gun safety legislation. This legislation bans individuals convicted of domestic abuse from owning a gun, and it includes tougher background checks for buyers under age 21 and bans them from buying assault weapons. It includes funding to encourage states to implement red flag laws to remove firearms from people who are considered a threat. And, very importantly, $15 billion in federal funding for mental health programs and school security upgrades. The bill also includes important new money for mental health. It funds implementation of 988, the new suicide prevention hotline, and training for pediatricians. And it extends and grows the Pediatric Mental Health Care Access Program with an additional $20 million a year for 4 years. This legislation is a significant step forward, and while we're encouraged by it, we know that our work is far from over. And we're here to help all of you who are working to prevent gun violence and promote mental health in your communities. We often call the times we are living in unprecedented, but there have been dark days and hard times before. The AAP was actually built for times like this. It was founded by pediatricians who navigated America through the 1918 influenza pandemic and who cared for our nation's children and families despite the hardships of 2 world wars, the Great Depression, and numerous other tragedies and disasters. We stand on their shoulders as we embrace our mission and tackle the challenges of preserving the future of our planet. And we are deeply grateful for the Inflation Reduction Act, which makes huge strides toward this. We're also taking on the challenge of defeating infectious diseases and creating social conditions in which all children can thrive. On behalf of the National AAP and staff, we are honored and ready to stand behind you in the work. Thank you for carrying out the vision and continuing the legacy of our organization, and for making a lasting difference in the lives of all the children of Arkansas and everywhere. I know you have lots to discuss at this meeting, and will apply not only the evidence and your knowledge and expertise, but your curiosity, your wisdom, and your compassion, and children will be better off. We pediatricians are so fortunate because in every child who comes to us, we see and hold the future and know that we must nurture that child forward so they can become their own healthiest and best self. Thank you so much for having me here today.
Well, I hope that you gathered just a bit of the effects of the AAP on the national level, and know that when you go to work day in and day out and see your patients, that you are appreciated, but also that you have an organization that's working to advocate for your patients and for us as pediatricians in many realms and things that most of us don't even think about on a daily basis because it's just too much. The AAP is supporting us behind the scenes and publicly as well. So now I have the opportunity to introduce our first speaker, and the bios for all the speakers are in the back of your book, but our first speaker is Karen Farst, and she comes to us by way of Texas, but she's been at Arkansas Children's where she did her residency, and then she did a fellowship in child abuse through Cincinnati. And then she's been with us here at Arkansas Children's for just a few years, working with the team for children at risk, and currently serves as the medical director. And I was just telling her she forgot to put in her bio that she was the chief resident of the Arkansas Children's residency program back when the same year I was the chief resident at Vanderbilt, and she and I met at a leadership conference in California and were trained together in that. So I probably have known her longer than most of the people in this room, but I'm sure that everyone has had an interaction with our presenter here today. So take it away, Karen. You think I just click it?
Am I going the right way? There it is. Okay. Well, good afternoon. See lots of familiar faces, and yes, I share, like, I'd have to get used to doing in-person presentations again, because I'm used to just like staring at my computer to do virtual presentations. So thanks for taking the time out of your schedules to be here. When the call for presentations came out, I was like, oh yeah, that'll be fun. You know, there's a lot to talk about. I enjoy being at the conference. I think I'll put a presentation in. And then she contacted me and said, hey, why don't you do the plenary? And I was like, well, that was not really what I had in mind, but okay. So we'll figure that out. But so yeah, there's probably not a lot of conferences that kind of kick things off by talking about child abuse, but we're really kind of hopefully go off of a little bit of the opening presentation and talk a little bit more about advocacy and some of the ways to hopefully prevent abuse. And I just, before I start, want to give a shout out to Anna and her crew for putting this together. And so did she step out? So if anybody else is uncomfortable with the fact that Anna won't call you by your first name, then I figured out that she has 2 master's degrees. So you can call her Master Strong, and that'll still differentiate her from her husband, Dr. Strong. So now she doesn't know I told you that. So everybody start calling her Master Strong, and then she'll realize what's going on. But they, just this is a lot of work, obviously, to put this together, and just really appreciate that. And to Susan for all of the board members and leadership. This is fun to be able to get back together. So the paddling upstream just kind of idea is the fact that I get tired of really kind of seeing what is coming downstream, and you feel like you're just consistently fishing kids out of just dysfunction, the social chaos, seeing issues related to abuse or neglect. So this is really about, can we take some time or just think about trying to get upstream and maybe keep some of those kids from having to get in the water and actually float downstream to us. So I have a lot of different things I do to try to kind of help my mental health with dealing with child abuse all the time, and putting cheesy pictures in my presentations is one of those things. So you'll just have to kind of put up with that as well. I do not have any disclosures similar to our foster care pediatrician president. Nobody really solicits me to come and speak or sell things for them. So just going to start out with a couple of brief slides just to kind of lay the foundation about just epidemiology. I don't really have to convince this room that child abuse and neglect is an issue, but just wanted to give you a little bit of stats about the state and just how we compare to the rest of the country. And then I'm going to focus on kind of 3 different areas just to think about. And I'm not at all asking you guys to go out and do all of this in your practice, but hopefully just presenting some thoughts or ideas. And maybe there's a couple of things that you could glean from it and take back to however you interact with people, whether it's in academic or private practice or hospitalist. I was in private practice for a few years. It's been a minute since I did it, but I just want you to know that I'm not asking you to like add more time to your already busy schedules, but do want to let you know about resources that are out there. So especially if there's something in your community, hopefully you'll find something that could maybe help. So the kind of the stats or the data that I'll tell you are from a national source called Child Maltreatment. And the most recent data is from 2020. It usually takes them a couple of years to analyze and put their reports out. This is basically child welfare data that's reported to a central database, and then kind of has some common rates and themes that are compared state to state. So if you look just at Arkansas, there are about 54,000 calls or reports made to our hotline each year. We have a centralized hotline system in the state. Of those 54,000, about 60% or so are screened in for investigation, and just really kind of from the upfront, about 40% of those don't meet criteria to investigate. That can be frustrating when you call something in and it doesn't meet their criteria. Sometimes that means you need to call it in and add some different detail, and sometimes it means that they're just taking it for information, and then it could show up down the line with another report in the future. Of the investigations that are screened in for investigation, about a third of those end up being substantiated or found true. So that means the information that the investigator finds meets whatever burden of proof they have to have. So just because a case is unsubstantiated, it doesn't mean that abuse didn't happen. They're not saying, no, this didn't occur. They're basically just saying there wasn't enough evidence to find it true. And that is hard in child abuse because we oftentimes are dealing with kids that can't provide a direct statement about what happened to them. And so it's not uncommon to see families have kind of multiple reports on them before there maybe is enough information to know for sure that something happened. So I'm unfortunately probably going to tell you a theme that you hear, that we exceed in areas that we really maybe don't want to exceed in as a state. So if you look at substantiated victims of child maltreatment, so this is now providing it in a rate per 1,000 child population. For the US, 5.9 of every 1,000 children, so that's under the age of 18, are substantiated victims of child maltreatment. And again, this was for year 2020. In Arkansas, we're almost double that rate. So we were 11 per 1,000, and that was over 9,000 basically victims or substantiated cases. So that ties us for the 6th highest in the country. Now, I would say this is about the best data we have to see how we compare to other states, but it's actually not always apples to apples when you compare states, especially for those of you that practice along the border and you maybe call into other states to report things to their hotline or deal with their child welfare system. Things are different. Every state has their own way that they investigate and find things true. So the fact that we have a higher rate, I think is real. You know, when you look at all of the other things that can kind of add to child abuse, we have a lot of it as far as domestic violence, substance abuse, things like that. But I don't want to say that it is just exactly kind of apples to apples. Fatalities related to child maltreatment. Again, we are 5th highest in that. So there were 30 that were kind of able to be identified in 2020 that were related to child maltreatment. And then when you look at just our youngest, you know, kind of our, we all are obviously attuned to kind of that importance of the 0 to 3 age range. And you look at the substantiated victims of maltreatment in kids that are infants, less than a year. Again, we are double what the national rate is, and we're unfortunately the 2nd highest in that. So again, I know that that's not necessarily news to you guys who see kids every day in every part of the state. But it is, you know, I guess the way you can look at it is we do have an opportunity to intervene and to try to make things better, because this is definitely something that's impacting kids across the state. So way back when maybe I guess Susan and I were just doing, you know, chief residency stuff, and I didn't even know I was going to do child abuse at that point. I was headed off to private practice at that point. The river felt a little more calm, and that's probably just because I didn't really know what was going on out there. But then as I decided to do fellowship and get into this and return to Children's Hospital, it was like, wow, there's a lot of this that I didn't even know was going on when I was a resident. You know, I saw the patients on the board, and you know, we would do rock, paper, scissors or whatever for who was going to pick up the next abuse case in the ER. But it was like, gosh, there's a lot of this going on that I never really even knew about. And now it's like, oh, just please let me stay in the raft. Just don't let the rapids bump me out of the boat, because it really just almost feels exhausting. But when we look as our group, when we look at ways that we can try to, you know, get out of just crisis mode and think about ways to prevent, it's kind of energizing to us. So, and I hope maybe that's a theme for different things that we'll talk about this weekend, that if you can find some ways to advocate and think about ways to plug into your community, it can kind of be refreshing and be almost a kind of a mental health break from our standpoint when we get to do some things like that. So we're going to talk kind of just again through 3 different ways. I am going to start with a little bit of medical geeky stuff because this is a medical conference. So we're going to talk about recognition and reporting, but then we will talk a little bit about trauma-informed things that you might be able to incorporate into your practice, and then end with just some resources about social determinants of health. So if you look from that same data source in 2020, medical personnel, we are one of the top 3 reporters to the hotline. We obviously see a lot of people, so we have an opportunity to be able to recognize and intervene early on. Teachers end up seeing kids once they hit school, but a lot of these, especially the 0 to 3 kids, unless they're in some type of a early kind of Head Start type of program, a lot of people, the only ones they're seeing are their primary care doctor or WIC or things like that. So it is important for us to kind of uh, be aware and be looking for things that would tell us it's a child that needs reported and needs an evaluation. So when we think just about physical abuse, there's some injuries that should be fairly obvious to us. And so if there's a patterned injury where really there's nothing else that would make sense for the patterns that are up there on the screen, other than that they were struck by an object or by something. So you can see the far left, so closest to me, there's actually kind of a combo of things. There's the loop mark on the right side of the ribs, but then there's also just kind of diffuse bruising on the left side. So, saying that the child fell down while playing outside or something like that is really not going to be an adequate reason for that. And this would, the middle picture as well as another loop mark. That one's nice to point out the fact that you can tell that that was a flexible object, like a looped over extension cord, because it actually wraps around the contour of the leg. So the history that you might hear, oh, they fell on something of that shape outside, doesn't really make sense because that's not like a flat fall injury. It is something that follows the curve. So we can get a little bit out of patterns, but the biggest thing is to recognize those, question them, and if there's not an adequate history for it, to report. The picture on the far right is actually a really classic pattern of what happens if the face is slapped. So the parallel lines are actually the space between the fingers where blood is kind of pushed into that area together with a slap. So again, there's some common patterns. We unfortunately don't see these that commonly. Usually it's more just diffuse bruising that we're kind of worried, well, maybe this is just an active toddler, maybe it's not. And so those are more difficult to me to kind of make a call about, does this need reported? Do I just need to follow this? Does it need worked up as a bleeding disorder? What else do I need to do? And we've actually had it. It's hard to do research in child abuse. We obviously can't do kind of controlled studies very well. But we have had some really nice things hit the literature in the last decade, especially pertaining to bruising and really how to address physical abuse. This was a systematic review of kind of looking at prior published studies and really just looking at where were bruises located when they ended up being associated with abuse and not. And this is not a diagnostic table. It doesn't mean if a child comes in with a bruise on their neck that you would report that right away without considering other things. But this is really just kind of the thing that would raise the red flag to say, be aware, look other places, ask questions, that type of a thing. So we kind of progressed from this, thinking about, well, sure. So kids that aren't mobile really shouldn't bruise very much at all. If you're just kind of learning to be mobile, your bruises should be over places that you hit when you fall down, like your forehead, your chin, your nose, things like that. But then we got a little bit more advanced with what was in the literature. Mary Clyde Pierce is a pediatric emergency medicine physician at Lurie in Chicago, and she actually did put together a prospective study in the emergency department where they actually mapped bruises for everybody that came in that would consent to their study. And then they looked at that forward, or kind of gathered all this data forward, and then looked back to see, again, where can we really kind of show prospectively that bruises were associated to abuse instead of accident. And so she came up with this mnemonic 10-4. So trunk, ears, neck for 4 years and younger, and then really any bruising on a child that's not mobile yet. And so this was really kind of one of our big hallmark studies in child abuse, because again, it's hard to do prospective studies, but this really launched quite a bit of additional work to where we really kind of started to think more about, this is our population that we probably struggle with the most, the little non-mobile kiddos, because number one, they're not verbal, so they can't tell us what happened. But number two, there's really just not a lot that they do that should cause bruising. So we really should have a really kind of a low level or a high level of concern when we see those, in order to, again, do a naked exam, potentially consider doing a skeletal survey to look for other occult injuries. And that kind of takes us back into when we think about our really highest risk that we have the biggest chance to intervene on is this young group. So this is our group that really is being impacted the most in the state, and it has one of the highest rates. So it's one thing that we, for the residents that are here, we really kind of hammer on them as well, as far as not just dismissing kind of things that might look like minor injuries. One of the other buzzwords that's come up in the child abuse world is the term sentinel injury. So if you think about who a sentinel is, they kind of stand outside, and if something bad's going to happen, they're the ones that blow the horn, yell, light the fire, whatever it is. They're there to warn you that something bad might be ready to happen. And this was a study that actually termed these otherwise kind of, we would think of them as minor injuries, like isolated bruising on the cheek, not really terrible looking injuries. They aren't truly patterned, but they are something that, again, in a child that really doesn't have the developmental ability to do things that would create these types of injuries accidentally, this can kind of tell us, hey, you need to take a closer look, and again, kind of consider a skeletal survey, think about other things that might be going on. And this launched us, you can kind of see from the dates, that's 2013. This launched us into really where we are now, that 10-4, the work that was being done at Lurie in Chicago, has now actually gone through some validation studies, and there's actually a validated bruising clinical decision rule. And so 10-4 has expanded. And so now it's not only trunk, ears, and trunk, ears, and neck, but then the faces. And this, I think, has been concerning confusing as we have tried to roll it out in the ED at Children's, is that faces doesn't just mean any bruising on the face. It's really a specific mnemonic of your frenulum, the angle of the jaw, the fleshy parts of your cheek, eyelids, and then subconjunctival hemorrhages. So we're not really talking about, again, kind of bruises over the bony prominence types of things. But then the 4 is really any bruise in a child 4 months or younger. So that kind of any bruise anywhere deserves kind of a deeper dive. And then, as we've already talked about, patterned. So this has been now validated to be, again, not a diagnostic tool. Doesn't mean, yes, this is abuse, but it is a decision rule as far as this deserves a deeper dive with it. So again, not just a little resource if you are in a practice where, a lot of times the nurses are the ones that are stripping babies to do weights up front. And so you can obviously kind of let them know to let you know if they're seeing something. We don't always strip everybody for quick visits if they come in for ear pain, throat pain, that type of thing. So it is just a way to kind of bring a little bit more awareness to your practice. If you want just some references or fun nighttime reading as far as a deeper dive into the evaluation of physical abuse, the AAP resources, especially PrEP, have a couple of really nice resources that outline and give you some tables about the evaluation of physical abuse and kind of the different things as far as like when skeletal surveys are indicated, and then also a nice read about just addressing neglect as well. So, calling the hotline. How many of you have actually called the hotline in person? Yeah, about half, more than half the room. Yeah. Was it a fun experience? No? Oh, come on. Oh, maybe a little bit, Erica. Did you have fun? You got to talks with them, didn't you? Yeah, exactly. Okay. Yeah, I do call, and it's not usually fun. There have been some good experiences, but it is a necessary evil. It can be very frustrating. So, our child welfare system, I'm going to try not to commentate too much, but our child welfare system is similar to a lot of other things in our state, just like our public school education. We really don't invest to have the system that we kind of expect or want it to be. We want the child welfare system to be everything for kids that are affected by abuse or neglect, but we really don't put the type of investment in there for it. So it is frustrating. And I will tell you straight up, I do this every single day. And some of my closest colleagues are people that work in the system, but I've had some of the most heated arguments with people that work in the system as well, because it is frustrating information. So I think it's actually better if you've called the hotline within the last 6 months. About 2 or 3 months ago, they were so low on staff that it was actually common to wait for 2 hours to be picked up. And so they have actually hired quite a few new people. I've called over the last couple of days, and 30 minutes is the longest I've had to wait. But it is still not convenient whatsoever. It can help you to kind of organize your information ahead of time. A lot of times, if you haven't called a lot, you'll want them to just kind of pick up, and you just want to start telling your story, and they want to get all their demographics in first. And so they do want to know what county it is, who the family is, that type of thing, before they ask you kind of, okay, now tell me the story. It can be very, very helpful. So if it is a patterned injury, if it's a fracture, if it's an ingestion of a methamphetamine or something like that, those are usually fairly straightforward. If it's medical neglect, if it's moderate persistent asthma and it's a child that's non-compliant and continuing to come into the ER, you do need to kind of have the what if, because they aren't that excited about people that just miss appointments, but they do want to know that somebody that's not filling their meds and not receiving specialty care is at risk for death from their asthma because of that disease process. So sometimes you do have to kind of spoon feed a little bit of the so what in order to get the response that you want. After it's accepted, I would just tell you that the investigators are not very good at taking time to reach back out to you, especially if it's a medically complex case. So, if you can identify someone in your practice, and if you happen to have a social worker, that's great, that can kind of figure out who to call in your local area to find out who's been assigned. We really do oftentimes, especially in the FTT cases or that type of thing, we have to kind of push things along and make sure that it is something that they are receiving the information that they need. It is okay if it is really kind of a not necessarily urgent safety issue that you can fax in a report. They are finally working on developing an online reporting system, but it's probably going to take a year or so before it's ready to go. I haven't been overly trusting of the fax system, but it is available. And if you've been waiting on hold for over an hour, you get probably more willing to use the fax system. I'm going to talk just a little bit about child sexual abuse and not do a huge deep dive, because this isn't really something that I would expect folks to do in their primary office or even in a subspecialty area other than the emergency department or our clinic. But one of the things that does present are young kids that come in, and there's either kind of an outright disclosure that they've had like discharge, redness, burning, that type of thing. And somebody thinks, well, maybe it would be a good idea to screen them for STDs. And we really have the opportunity to do non-invasive urine screening for STDs now without having to do swabs. But the thing that's really, really helpful in these cases is if you do get a urine that comes back for chlamydia or gonorrhea in a prepubertal child, please don't put them empirically on antibiotics. Go ahead and report that first. Let the investigator kind of get them hooked up to get a specialty medical exam, or call us. We're happy to do that. But if you have a urine in a prepubertal child that's positive for an STD, there's actually an extra step of confirmation that needs to be done since it's not a culture. And if we don't get that on the very first urine, then sometimes we can miss that opportunity. So to try to put your minds at ease, we usually are very quick to try to treat, especially girls, when they have an STD because we're worried about PID, but that's more of a post-pubertal phenomenon. So prepubertal girls really don't have the vaginal flora and just kind of the physiology that they're that at risk for ascending infection. So please hold off on the kind of the urge to treat those folks until all of the testing is done. I don't have a great answer for what I know all of you that are especially in primary care deal with, as far as they came home from dads, they look red, I think somebody sexually abused them, other than just being diligent with, screening for infection. If it's a child that's old enough to talk, you can try to give them an opportunity away from the parent to ask them if they feel safe, that type of a thing. But a lot of time that is kind of turning that back to the family to say, if you have a specific concern for abuse, you need to report that to the hotline so that the appropriate investigation can take place. I know that all of you probably deal with the fact that folks want to kind of pull you into the investigation and make you part of that. But if you can get them into the hotline system and they make a report, there are actually entities across the state called Children's Advocacy Centers, and they're really primarily to kind of coordinate the community response to sexual abuse. Who all is familiar with that there is a CAC in their area? A few of you, yay, that's very encouraging, great. So there's 17 in the state, and they do have a few satellites as well. You can kind of tell by the map, and if you don't know the CAC in your area, there's the website where you can kind of find out. But the CACs are based off of a national model that's really designed to bring evidence-based approaches into the community level. And again, it's for all forms of abuse, but it's mostly centered on sexual abuse, because sexual abuse oftentimes doesn't have physical findings on exam. It really depends on the disclosure for the child. So at the Advocacy Center, there are folks there that are trained to how to do interviews with kids. There's advocates, there's people that do a mental health assessment. And all of the CACs have some level of medical coverage. For most of them, that is an RN that then has had specific training as a sexual assault nurse examiner or a SANE. And so they are trained to do that specific type of an exam. They are all connected to our program by telemedicine. So if they have a question about something, we can help, but they don't work for us. We aren't their overseer, but we're happy to help with questions or try to connect for you guys, because they will do kind of the photo documented detailed exam, test for STDs, that kind of thing. The other issue to know, though, is that you can't refer to them as a primary care physician like you could refer to our clinic at Children's. Children's advocacies are limited to taking referrals from investigative agencies. So that's why you really kind of have to steer folks to make the report, and then the investigator can get people set up that way. So the last category on this, and it does fall back into this, really, again, kind of high-risk group of infants, would be drug-exposed newborns. So in Arkansas, the law that mandates that we as healthcare providers report to the hotline if the baby or mom tests positive for an illicit substance at birth is called Garrett's Law. It's named after a child that actually died following birth, and the mom did have a methamphetamine issue. There was really, kind of like everything else, nobody really can say that Garrett passed away just from methamphetamine use. It was a premature delivery with lots of complications, but for better or worse, that name has been now tagged to this law. And so that's what you'll hear, and DHS refers to it that way as well. So in our state, there is not, as you guys know, there's not universal drug testing. So it's a choice of which moms and which babies get drug tested. We do certainly encourage using an objective criteria of who to test to try to minimize bias. If you don't have something like that in your nursery, the UAMS Angel site has a kind of a set of guidelines that is based out of the literature that you could refer to. But it is important to know that positive tests during prenatal care are not included in Garrett's Law, because I hear a lot from our maternal health providers that they really don't like Garrett's Law because they don't want to push women away from prenatal care and kind of the fear. And that's not Garrett's Law at all. Garrett's Law is really meant to identify people that are using at the time of delivery, and then to do an assessment on those folks to make sure that there's a safe home for the baby to go to, and that the mom is getting offered the services that she needs in order to try to get clean. Our part of that from a medical standpoint is really kind of several-fold. If you're drug testing in your nursery, make sure that you do have some type of confirmatory strategy. So if we are reporting positive screening tests out to people that aren't medical and don't understand the difference in a screening and a confirmation test, then we're potentially, entering people into the child welfare system that maybe that's not an accurate test. So do try to kind of make sure that you are practicing, good toxicology at your hospital and being able to have confirmatory testing. And then when you report, I think it is also helpful just to help remind DHS that it's really not about necessarily the fact that mom introduced drugs into the baby system. It's about the fact that, hey, this is a sign that this mom may have a substance abuse issue. So let's, as a team, let's assess to see if there are services that she needs, the family, let's look for domestic violence, all those types of things. And then probably most so, if you round in the nursery, work with your case manager, work with if there's social work, but get together a discharge planning kind of strategy to where you are involving nurse home visitation, home health, making a warm handoff for primary care. That's really one of the best things you can do, is try to help support and give structure to what's going on with these cases. And you're going to get some, I think, good information tomorrow about just following developmental, because that's one of the big things that we can do in our health supervision exams then, is just to try to catch those kids if they do have signs of developmental delay, that they would be able to be plugged in for early intervention referral. You may or may not this is more of a child welfare kind of term, but there's the federal law that governs funding to the states to run the child welfare systems is called CAPTA. And CAPTA has a clause in there that says that every state has to have a mechanism to develop plans of safe care for infants that are born affected by maternal substance use. So the affected by is this very vague term. And so states have interpreted this differently across the country. Arkansas's response to this is Garrett's Law. They tried to make Garrett's Law as non-punitive as possible. So if a mom is found to have been using drugs at the time of delivery, then she doesn't necessarily have to be placed on the child abuse registry unless there's another type of abuse found during the assessment. So it is meant to be supportive, but there are a lot of states who do not have mandated reporting. It's really just up to the practitioner to be able to assess if they think there's enough risk or not to report. But so that is, I think, where we can try to partner with our local DHS offices. Some of you have very strong local county offices. Some of you have offices like what Pulaski County has dealt with over the last year, where you've had 100% turnover times 2 over the past like a year to 18 months. And so it's just, there's always new people in that you can't kind of get on a roll with. So it is an opportunity for us to be able to try to advocate, educate, and try to focus people on what we're talking about, as far as not just trying to punish people, but trying to get services to families. So I'm going to get out of the recognize and report stuff and really through the last few slides, just go much more broad. And again, not at all trying to tell you that you need to incorporate all of this stuff into your practice, but really just wanted to provide some resources for things that I have found helpful in certain circumstances. And I would really encourage you for tomorrow, colleagues from the Child Study Center are going to be here to talk about the effect of trauma on kids, what that manifests not only in their mental health, but in their academic lives and everything like that. So I think you'll hear a deeper dive on this tomorrow. But I did just want to throw out a few resources for you. The group that's coming tomorrow will probably tell you more, but the RBEST, and so RBEST stands for Arkansas Building Effective Strategies for Trauma, is the BEST. They have a really nice website that not only describes just really kind of briefly for you or for families the different types of therapy that are effective for trauma, but it also gives you a searchable database by city or by county for the state as far as who has actually been trained in these modalities. It's not an endorsement list, it's not an advertisement list, but it does at least let you search to see who's been trained in your community in therapy for kids who have been sexually abused, witnessed domestic violence, things like that, and things that will oftentimes come up as you are screening kids for ADHD issues, mental health, that type of thing, or you just know that that is something that the child is dealing with in their home environment. a plug for, Anna talked a little bit about this, but the different resources that AAP has put together, they actually have a really nice series called Connected Kids, which is specifically targeting violence prevention. So most of us, I think, are familiar with TIP, the injury prevention sheets, and those are meant for accidental, to prevention of accidental injury. So Connected Kids is really what TIP is for accidental injury to non-accidental injury. But they're also similar to TIP. They're graded through the developmental kind of stages. So the early sheets talk about, you know, what to do when your baby's crying, how to have a crying plan, the fact that if you feel upset or feel like shaking your baby, that is something that you need to have a plan for how to set the baby down, walk away. But then it goes up to and talks about positive parenting strategies, how to deal with the fact if there's bullying going on, TV violence. So a really nice set of kind of handout things that can give you a rubric to be able to use that in your practice. If that's a issue that you know that you're going to need to deal with that visit. And then I also really like the another AAP resource, the healthychildren.org parenting info about positive parenting. They have information that's both in English and in Spanish. And that's really, I think, one of the things that our group has tried to be intentional about, finding opportunities to be able to kind of teach, model, explain, not just preach positive parenting, because we see so much corporal punishment when somebody basically loses their temper during a corporal punishment event, and you end up with a child like on the early pictures where they've been beat and not, you know, just basically kind of punished in a, you know, in a controlled type of a manner. So I know Arkansas Children's has really worked on being like a no-hit zone. Many of your practices may be that way as well, but that's really for us something that kind of helps to hopefully charge us up, is to find ways to try to reverse the trend of just kind of accepting corporal punishment as an okay thing for behavior. And then the last part before just taking an opportunity just to hear from you guys and let you ask questions is to, and some of you may, and you can share with each other too, have a way to screen and address the impact of social determinants of health. So this isn't just tied to child maltreatment, but social determinants of health is tied to child maltreatment. So we know that the stress that people are under from a financial standpoint, all the different things that we talk about with food insecurity, housing instability, that stuff is related, because it is an extra layer of stress in families' lives. And so, and Children's has been intentional about trying to build some of that screening into visits on the campus. And that's something that we have been trying to do, just because we routinely see at-risk families, as far as trying to be creative with grants or resources that we can to be able to meet things for housing instability or trying to get transportation reliable. But wanted to make sure that you were aware of it's a national database, but it is mapped down to kind of the state and local level now. It used to be known as Aunt Bertha, if you've kind of heard of Aunt Bertha before. But Aunt Bertha was renamed to a little bit more professional name, and it's just called findhelp.org. But you can kind of see from the screen up there, you can actually just put in your zip code up at the top left up here, and then it will bring up really what's around you for things like food banks or housing assistance programs, just different things like that. So we are super spoiled at Children's because we do have a social work department and we have case managers and different people like that. But sometimes you do kind of just have to do that dive on your own as well. Yeah. And especially if you're in your own practice and don't have that level of kind of social support resources that are there. So this is a good one. You know, if you have been in practice for a while, you probably know what's in your community and kind of have some of that built up. But this is a good one just to kind of keep on your desktop as well. So that's my paddling discussion. I wish I could tell you at the beginning that I knew how to stem the tide. I don't know kind of people have asked me, has child abuse gone up during COVID? And it's like, well, stress has definitely gone up during COVID, and we know mental health problems have. Domestic violence definitely has. What we saw in the recession of 2011 is that child abuse kind of lagged behind all of the stressful things. And then we saw that really go up kind of 2 or 3 years out. And that's what it feels like right now. I don't know that we're far enough out from COVID and all the stress that we're still under to really know what the impact is going to be from a child abuse number standpoint. But, no surprise at all to this room that families are definitely stressed and people are having a hard time just keeping up with all their social determinants of health. So there's unfortunately ample opportunity to try to get upstream and stem some of this. But we're going to have to continue to work with our groups like AAP and Arkansas Advocates and the legislature to try to continue to really kind of fight for programs that do try to strengthen families instead of just waiting for there to be a catastrophe to respond to. I don't know, was that like terribly depressing from a child abuse standpoint?
I feel like I tried really hard to put a positive spin on child abuse, which is hard, but let's thank Dr. Farst. I know Anna had mentioned earlier about the little buttons on your microphones and pushing the one that looks like a speaker if you have a question. So if anybody has a question, you can do that now. Okay, I see one that's lit up there.
Oh my gosh, and it even takes you to the person.
No, that's just
Wow.
like gonna discourage people from asking questions.
They can't see it.
Oh, they can't see it.
You
Oh, okay, I see.
Oh, no, they can see it up there.
Oh,
Yeah. So
yes.
You have the target on your back before you start to talk.
that's right.
So thank you so much, Karen. Your work has been instrumental in the lives of so many people. I was in practice for 13 years. And when I went into practice in Jackson, Mississippi, my clinic, which was the oldest pediatric clinic in Mississippi, was the last clinic in Jackson to stop taking Medicaid.
Mm.
So it was a pretty affluent demographic of patients. And the notion among the people that I practiced with was that child abuse would never occur in this population of patients. Well, it turns out they were wrong.
Mhm.
And in fact, at that point in time, at the Children's Hospital, which was directly across the street from our clinic, none of the people over there would touch child abuse.
Mm.
None of the pediatricians, none of the OB-GYNs. So one of the female partners I had took this on, and she did what you're doing from a private practice point of view. So I learned a lot from her and was able to help her more with the physical abuse stuff. And she really focused on the sexual abuse stuff. But the point I'm making is just awareness.
Yeah.
I think that's the biggest thing. So in your practices, focus on these things Karen has pointed out to you that are resources to help train your staff. So when your nurse is taking those kids down to their diapers to do their vital signs, that's the perfect opportunity to be aware of what could suggest perhaps a greater discussion of what that little mark means.
Yeah.
So thanks again for all you do.
And thank you. And that's really been, I think, one of the biggest pushes I've seen since this information over the last 10 years, especially, is to really try to find a way to get the subjectivity out of deciding who to work up and report and try to be more objective. It's never, I mean, it's never going to be totally objective. I don't know if Erica knows, but we're going to roll out some trigger guidelines in the ER at Children's to really be able to focus on more objective indicators. And that's what I think really 10-4 Faces P has been the thing that's really kind of pushed that forward, to be able to just, kind of look more at injuries and whether or not there's an explanation for it rather than, do you like the family? And that's hard in primary care because I was there for a few years and it really, when you have somebody come in that you just would never think that would happen, it's hard to get to the point of thinking that you'd have to make a report. But you always do have to know too that there's always more behind the story than what you kind of see on the surface as well. Yeah, thank you.
Your light's still on. I don't know if you're supposed to push a button. Okay.
Oh, okay.
Thank you. Does anyone else have a question? I don't see. Oh, okay.
Hi, I have a question about if you do have concerns about abuse in the middle of a clinic visit, how do you sensitively broach it or bring it up to the family saying you're gonna have to make that call?
As far as if you're asking the family to make a report that you're concerned, or that you're going to make a report that you're concerned.
If I, as a provider, am going to make a report.
So yeah, if you see an injury that there's not an explanation for, and again, easier said than done. It's easier for me because I don't really have an ongoing relationship with most of the families I see, and you obviously are if you're going to be their primary care provider. I do try to norm it as much as I can and say, what we're going to talk about is not going to be easy, but I feel like it's important for you to know upfront what I'm concerned about, because this is all about the concern about the safety of your child and not about me judging you. But there is an injury that does not make sense for the history that you've provided. And I don't see anything medically that would cause this. And so I'm actually mandated by law to make a report to the hotline so that there's an investigation that's done outside of the hospital or office. And I usually do tell people, this is what I'm going to tell the hotline as well, that there's an injury that doesn't make sense. I'm not going to tell them that I don't like you, or that I don't think you're a good parent, or you don't love your child. But I am obligated by law, if there is an injury that doesn't fit the history that you know of, that I have to make a report to the hotline for that. So sometimes that goes okay. Sometimes that does not go okay. And that is a good thing to have a conversation with your office about. What do you do when a patient escalates? I mean, this is certainly something that could escalate a parent. There's other things I'm sure too that you guys would deal with, but being able to have whatever your kind of code word is in the office to be able to say, I need help. In those kind of situations, if I really do feel like it's somebody that might escalate, I'm going to try to get the parent to a, different quiet room and not necessarily in the middle of the clinic. And I'm always going to have somebody in the room with me. And I'm always going to be the one sitting closest to the door. So, we can push a panic button at Children's and have security come. You can't necessarily do that in your office. So you need to have somebody that knows that if you say whatever the word is, that they're dialing 911 for you as well. It doesn't, usually escalate that bad, but it's one of those, just like active shooter, it's good to have a plan so that when you need to put it into place, you have it. But that is what I do, is really just what you really kind of need to know going into it is this severe enough that I would actually put a hold on the child if the family tried to run out of the clinic? Or would I just say, I'm going to make this report, please expect a call from the investigator? I would probably say, if you think that it's something that's severe, like if it's a fracture or bad burn, that you would actually potentially go ahead and transfer that kiddo to an ER by ambulance. And then, kind of let the report, you can make the report as the child's headed to the ER. So that way, the child's safe. Does anybody that does this in private practice have a really slick way that they do it? Aaron's got his mic on, so that must mean he does. No, he's saying, no, I don't. He's waving it off. Not here. Did that help at all? That's, they are difficult conversations, but I just try to be very honest with them, and just say, I don't want to do anything behind your back. I'm going to, tell you what I see and why this is concerning to me. You probably need to turn on, because if is it zoomed or is it not? Nope, everything's on. Okay. Oh, that's because Aaron's got the next spot up there.
Turn mine on. Oh, not working.
Yeah, go ahead. I'll repeat it if we do. No, he's off. Go for it. Yes.
So back to follow up that point is, a lot of times primary care providers are reluctant to report for fear they're going to be called to testify.
Mhm.
So I think y'all need to know that Karen and her group are there to help you get prepared for testimony if it comes to that.
Mhm.
And there's nothing frightening about testifying. I keep in mind that I'm there for defending this child from further abuse or whatever the problem was. And just like with any other part of medicine, as long as you know the facts about the problem you're going to be likely to be questioned about by the plaintiff's attorney or the defendant's attorney rather, you'll be well prepared and you'll do your patient a world of service by being well prepared. I think that's being prepared for testimony is just like cramming for a test. If you have the facts before on your fingertips that you can rattle off, it's going to impress the judge and it's going to impress the jury if there is one.
And thanks for that. And I should have said at the beginning, we're happy to be a resource for you. If you just want to talk through somebody, if you want to talk before you make a conversation with a family, there's always one of us. There's 3 child abuse pediatricians now with the group, and there's always one of us on call through the ACH operator. Yes, Aaron.
My turn. My question was just the regional advocacy centers. I don't know if I have the name right, but I think more often than we get truly reportable cases is we get the parent who's concerned, like you alluded to, they've been at a friend's house, family member's house, and there's a concern, but there's no hard evidence of that there's been an episode of abuse or something, but we maybe need assistance with just that diagnostic interview. Do those centers provide that? I know here in Little Rock, I've, shuttled people your way, but I didn't know if there's a more regionally available resource for that.
No, that's in the Advocacy Center for Pulaski County is actually co-located with us on the ACH campus. But there's really not a diagnostic interview group that's outside of the hotline system. And that is, kind of the issue is that there needs to be a hotline report in order to kind of activate that system. The Children's Advocacy Centers that you're talking about, the regional, they are only activated when there is an accepted hotline report. So for those kids that maybe are having problematic sexual behaviors, doing some things like that. If there's not any, kind of firm physical indication that abuse has occurred, a lot of times the thing to do for them is to refer them to somebody who is trained in trauma-focused therapy, because then as they get a rapport with that child, the child may then be able to disclose what's going on and then they would report. But no, there's not really, there is kind of no resource to do a diagnostic interview really kind of outside of the hotline reporting system. Yeah.
I had just one more kind of along that same kind of clinical practice. When you do have people come in with those kind of concerns, they were with a family member, whatever, and they're like, well, I just want you to test them for everything. And you might, of course, physical exam is going to be normal a lot of the time anyways. And for me, that's kind of a tough one because it's like, well, if I'm going to test this kid, then that means I have at least a high enough index of suspicion it sounds like I should make a report. And that's a hard one for me because, that's the kind of report that they'll say, okay, well, we're not going to investigate this, which, okay. But should we try not to do that kind of testing? If a parent's asking for it, do we do it and not make a report?
I think I think it's fine if you don't, if the parent's just asking you to screen for something. I don't think you're obligated to make a report unless you get a positive test back. So, but if your urine on your 5-year-old comes back positive for chlamydia, then you do, obviously. But no, I don't think that testing just in and of itself would be the mandate as far as suspicion, because you're basically just kind of screening at that point.
Okay.
Yeah. Thank you all very much. Happy to chat with you between sessions as well.
Well, it is a relief to know that we have people in our state that are doing that type of work because it's a difficult field to embrace. So thank you for you and your team and all the work that you do. I think Anna was going to come down and make a couple of quick statements before we take our break and then head to the breakout sessions.
I was sitting by Aaron and I had actually stepped out and missed that, but he filled me in that that's my new nickname. So thank you again, Dr. Farst. I appreciate you.
Thanks so much. We're really happy to be here today. We wanted to share with you what we do at the Poison and Drug Information, which can not only help you, but helps our communities and helps our state by serving 3 primary missions. I do have a financial disclosure. I receive an honorarium for being on a board that reviews online toxicology manuscripts, and I write a section on acute iron poisoning for Up to Date, but Charles and Pamela have nothing to disclose. So how we're going to do this session is introduce you to frontline worker Pamala, what she does as a certified specialist in poison information by telling a story and give you a little overview of what the Poison Center does. Next, I'm going to review with you 3 over-the-counter medications that have escalated in calls, not only to poison centers, but emergency department visits, and talk to you a little bit about the expertise information that we can provide to you, as well as the medical toxicology services the Poison Center provides. And then finally, we're going to end with Charles telling you a little bit about public education. That is a primary mission, because we want to prevent poisonings, both unintentional poisonings, but also serve as one of the modalities in integrating with mental health services and resources in our community to hopefully prevent the escalation of poisonings in our adolescent population. So Pamela is going to start.
Hi, thank you for allowing me to come and talk about something that I'm passionate about. I've been at the Poison Control Center for 26 years. I jokingly tell them they'll have to wheel me out of there in a wheelchair after my retirement age. So, but I'm excited to be here. And I wanted to tell a little story first. This one's fairly benign. Fortunately, there are other cases we have that are not so benign and don't end up so well. But I'd like to tell you about a call I received. It was directly from a 15-year-old girl. She was actually at school at the time of the call. She professed to me that she had overdosed on naproxen, and she did have an intent to harm herself. The amount she ingested was not highly toxic in its amount, but her intent was absolutely there on trying to harm herself. We do calculations, we get a good history. And then I actually told her that we needed to send her to the hospital. At that point, I talked to her and convinced her to reach out to the school nurse and the school staff. She did do that. I did follow up with the school and verified that she was getting assistance. I did speak to the school nurse. We actually then called ahead to the emergency department and reported on the history and gave them the full history, really talked to them about what was expected, that this wasn't necessarily a severely harmful situation, but it was something we needed to investigate and do some lab work and really confirm that it wasn't some of the other ingestions that Dr. Liebelt's going to speak of acetaminophen or aspirin or other things. She had some mild abdominal pain, mild nausea. All her lab work was excellent. And she was later that day discharged to a psychiatric facility. So it was a great outcome. Not all of them are that. I'd like a quick show of hands on if anybody has called the Poison Control Center. Great. So I need to convince the rest of you about what the benefit is. How are calls handled and answered at the Poison Control Center? When you call the Poison Center immediately, it may ring a few times, but you're actually getting a person. You will immediately, you won't go through a press 1, press 2. You're going to reach an RN or PharmD. It's staffed 24 hours a day, 365 days a year. All calls are confidential. All calls are free. All calls are HIPAA compliant. We triage calls. So if we have multiple cases going on, you might by chance have to be on hold for a second. I was alone this morning while I was staffing and had 4 calls going on at the same time by myself. So I did have to triage some, and there was a little bit of hold time. We gather information, history, demographics, clinical symptoms, product ingested, where they're located. So we know what facilities and what resources are available. We make an assessment. So as a healthcare professional, we do determine, based on the information we are given at the time, we do determine the toxicity, whether it's a situation where it's something that we can manage at home, give some, recommendations on what to do at home, or whether they need to be monitored and sent to a healthcare facility. We get all kinds of calls. We get calls from parents at home. We get calls from the kids themselves, from industrial sites, whether they have a exposure at a workplace, from emergency departments who have a significant injury or suicide ingestion or chemical exposure. We get snake bites, spider bites. There's a wide gamut of calls on the topics that we cover. Management, once we decide whether it's home or healthcare facility treatment, we do follow-up calls. So we follow up at home. We actually will follow up in the hospital. So we will annoy you in the emergency department. And we're trying to collect data. We're trying to not only prevent poisonings, and Charlie is the prime person that's his role, is to get the word out and educate people and educate parents, but we also try to improve outcomes. And so that's really important. And we do that by just really kind of assessing, therapy that's given and kind of make sure we're on track. We do have electronic medical records. We do ask a lot of questions, and we type and fill it in as we're taking the call. We gather a full history. We try to make a clinical decision. Our information minus patient identifiers is auto uploaded about every 7 to 8 minutes to a national database. So there's actual real-time toxico surveillance that goes on in combination with all the other poison control centers in the United States. And at that, I will let Dr. Liebelt.
Thanks so much, Pam. Well, I think most of you are aware about the escalation of not only mental health, illness, diagnoses, and visits to the emergency department, but certainly the number of poisoning episodes. This actually started to escalate before the pandemic, but in addition to the absolute number increasing, the complexity of overdoses has been increasing. So when I was training in the early 1990s, I'm really old, the typical adolescent poisoning that came in the ER when I was training was usually a single substance exposure, like a Tylenol overdose. That has dramatically changed in the last 5 to 10 years. The age span of poisoning, not just the teenager, but now we're seeing pre-adolescents. We're seeing older population where we're seeing increasing numbers of intentional poisonings. Unfortunately, the number of deaths due to poisoning have been escalated, and that has been fueled not only by the opioid epidemic that again started before the pandemic, but also by the increasing number of psychiatric medications that are available to many of our adolescents. This has placed an incredible economic burden on our society, not only in the United States, but internationally. Whoops, sorry about that. This is just a paper that was published before the pandemic, looking at sex and age-specific increases in suicide attempts by self-poisoning. And you can see that blip And it's a very consistent blip in our National Poison Center data around 2011 and 2012, where we start seeing increasing numbers, not only in 13 to 15-year-olds, but 10 to 12-year-olds. This was a very large study, again, using National Poison Data System data from all the poison centers. Now, looking at increasing trends during the COVID pandemic, I think this graph shows the trend that we all have been hearing about. The top line represents 2020 proportions, and the bottom line represents 2019. And basically, you can see the trend. Emergency department encounters among youth with suicidal thoughts of behavior during the COVID pandemic. Now, this includes not only ingestion, self-poisoning, but all suicidal thoughts and ideas presenting to the ER. This is a very interesting study that my colleague out in Oregon did, looking at pre-adolescents. I find this very concerning, where looking from 2015 to 2012, and again, these are in younger pre-adolescents. He defined them 9 to 12 years of age, a 4.5 increase in calls, 10 to 12, not 9 to 12, with suspected suicide intent through self-poisoning. Why are we seeing these emerging trends? I think listening to the AAP presidential statement, and again, you know as pediatricians why this is occurring, increasing mental health diagnoses, increasing prescribing of psychiatric meds. We have seen a marked increase in ingestion of over-the-counter medications, even prior to the pandemic. The pandemic itself, for all the various reasons that we've been reading about, social isolation, et cetera. The internet has played quite a role, social media, but also I think somewhat of a silver lining, more open discussions about mental health, reducing the stigma of mental health. And that's why I believe we're seeing more visits to the emergency department, people asking for help, which I think is a good thing. So I'm going to go over 3 cases with you. And my first case is impact of social media with an over-the-counter medication. This was a 16-year-old who presented to our ED after ingesting a whole bottle of unknown pills sometime in the last couple hours. You can see her vital signs are abnormal, mild elevation of temp. She's quite tachycardic. She's hypertensive. She's very agitated, hallucinating, very large pupils. So we did our ABC assessment, an IV was placed, labs are drawn. And in the first 20 minutes, she has a generalized tonic-clonic seizure. Hank Farrer's on call now for our service. And last night he had a patient exactly like this in the ER. This is not uncommon. So diphenhydramine or Benadryl, increasingly being abused for its reported high, increases in self-poisoning attempts in adolescents. Remember, Benadryl is over the counter. It's FDA approved as a sleep aid. That's what it says on the bottle, as well as an antihistamine for allergies. Also, what's becoming sort of new in the last 10 years, you can buy it in bulk at several stores, including Walmart, Costco. Easy accessibility, okay? It's not illegal. Anybody can go to Walgreens and buy Benadryl or Costco. So the accessibility is much greater. Well, then what did we see in 2019? I didn't even know what TikTok was. I'm being very serious. I had no clue. This Benadryl challenge on TikTok, there were deaths Okay, deaths. The FDA came out with a warning in September of 2020 during the pandemic, delineating its concerns about diphenhydramine and this Benadryl challenge. Basically, you know, these people got on TikTok and said, oh, keep taking it because you're going to feel great and you're going to start seeing cool things. And there were deaths due to this. I actually got very interested in diphenhydramine before the pandemic. This is a paper I published with some colleagues at the University of Washington, again, using national poison data. And again, you can see the trends starting in about 2012, not only in ages greater than or equal to 10 years. Look at the escalation. These were single substance diphenhydramine exposures, calls to poison centers, and not only in the 15 to 19 year age range, but look at the purple line, the 10 to 14, a 218% increase. The clinical toxicity, many of you guys are already aware of. We see anticholinergic signs and symptoms, this dysphoric delirium, psychosis, visual hallucinations, tachycardia, but also we can see extreme sedation, seizures. But also many of you may not be aware of some of the cardiovascular toxicity. Benadryl has sodium channel blockade, just like the tricyclic antidepressants, causing QRS interval prolongation, wide complex tachycardia, hypotension, as well as QT interval prolongation with a risk for torsade de pointe. So Dr. Farr's case last night, she not only had seizures, but she became hypotensive, requiring vasopressors as well as intubation. Our ABCs, again, may include intubation, GI decontamination. I need to save that discussion. That's pretty complicated in a setting like this, but certainly we might consider giving charcoal once the patient's intubated. Seizures, benzodiazepines. If you need a second line agent, as this patient did last night because she had multiple seizures, you could try barbiturates, although I kind of don't do that anymore because of their cardiovascular effect, Precedex, short term, or levetiracetam or Keppra. And that's what the patient last night was put on. Physostigmine, we say for pure anticholinergic delirium, it works. It works really, really well. But there are some stipulations on when you should not give it. If there's any chance there's a tricyclic on board or another drug that blocks sodium channels, I probably wouldn't give it. But boy, when you have a very agitated patient who's at harm for himself, who is violent in the ER, you give physostigmine within 10 minutes. It works very well. And sodium bicarbonate for wide complex tachycardia and hypotension, just like with tricyclics. All right, you guys are all familiar with this, okay? Acetaminophen poisoning, same story for 60 years, and it still is happening. Okay, I find this epidemiology very, very interesting. It's one of the top ingested substances reported to U.S. poison centers, both unintentional and intentional reasons. It is the most common co-ingestant in polypharmacy overdoses. That's why we always check an acetaminophen level. You know, you say, well, why, Erica? Come on, why? Because we have an antidote, unlike the other 3,000 drugs, okay? We have an antidote. It is still the leading cause of acute liver failure in the United States. That just astounds me, okay? But we have an antidote. And then we have so many multi-ingredient formulations. I put pictures of them. Now we have this combination ibuprofen, acetaminophen. I don't know if y'all are aware of that. So that's why our poison information specialists are so astute when asking questions. Well, do you know what kind of Tylenol it was? Well, it was Tylenol. Yeah, but there are about 50,000 different types of Tylenol. And there's co-formulations with Benadryl. And that kind of changes our management and how we get multiple levels. There's extra strength Tylenol. There's Tylenol extended release. There's Tylenol arthritis, etc. So just to beware. There, we have clinical stages of acetaminophen toxicity. Not all the people who ingest acetaminophen overdose follow these, but they're fairly predictable in terms of nausea, vomiting, and abdominal pain, and your LFTs are going to be normal, you know, in stage 1 in the first 6 to 12 hours. Then you start seeing liver injury developed after 24, 36, 48 hours, and maybe some right upper quadrant pain. And then stage 3, and we call people who present at, 48 to 72 hours later, the late presenters. These are the people that many times present an acute liver failure. And that's where it gets tricky, and how we've sort of changed our therapy, because we continue to give them the antidote, but they may go on and need a liver transplant. And then there's a recovery stage. So basically with acetaminophen, you're either going to get better or you're going to develop fulminant hepatic liver failure and require a transplantation, or you're going to die. Now, there are many people who develop severe hepatotoxicity and reverse without a liver transplantation. But really there's only 2 outcomes. Most of you are familiar with the Rumack-Matthew nomogram. Dr. Rumack, as a pediatrician, developed this. And again, we predict who is going to develop hepatotoxicity, need for treatment based on this nomogram. However, this is again where acetaminophen gets tricky. These are only for acute single ingestions. And if you get a level before 4 hours, it really isn't helpful unless it's 0. It helps us to rule out. And sometimes, the little kids who are found with liquid Tylenol, and we don't know how much, and it's all over their mouth and their shirt, and we don't know how much, if you get a level at 3 hours and it's 0, they're going to be okay. All right. But this gets really tricky too, because we are seeing more and more patients. Now, we don't know when the time of ingestion ends. So we have an antidote in acetylcysteine. However, what has changed? We now have IV NAC. Not every hospital in Arkansas has it. That's okay. Oral NAC is still totally fine to start. What's the problem you get into? If they're vomiting a lot because they're toxic, they won't tolerate it. Okay. So IV NAC. And what is new in the last 10 years, now people are talking about different infusion doses and treatment. The FDA package insert has a 3-bag method, and I see some of the residents, they know. We developed a new 2-bag method at Children's because we wanted something that was simpler to do, and we built an order set, although the same dose of NAC is being infused. We do extended treatment now. We have a acetaminophen toxicity clinical pathway that helps guide everybody through that. And of course, we are always available to help you. Certainly liver transplant may be an option for somebody in liver failure. We don't do that here at Children's. Most of those pediatric patients, as I understand, are referred to St. Louis, to WashU, I believe. Now, other emerging trends are the massive overdose. I see Dr. Rainey in the audience. He and I took care of a kid with a massive overdose, 30 grams or more. We treat those with higher doses of IV NAC. And now there are certain patients that I believe will benefit from hemodialysis, very, very high levels over 800, in conjunction with metabolic acidosis and encephalopathy. So lots of new things have happened with acetaminophen. Aspirin. Well, before we had Tylenol, What were kids dying from in the 1950s and 60s? Aspirin poisoning. Okay. How did poison centers even come about in the United States? The very first poison center was in Illinois in 1953. Pediatricians came together. Why? Kids were dying from aspirin poisoning. Well, then aspirin kind of went away when Tylenol came about in the 1970s, but then aspirin came back. Why? We're using it. It's available in the homes. Older adults, or well, not older. Well, I'm an older adult, but you know, for prevention of stroke, for prevention of myocardial infarction, but also it's a great pain reliever. But again, what are we seeing now? Resurgence of aspirin ingestions. We don't know. If you go into Walgreens or to Walmart, they have pain reliever. So sometimes the poison center gets called and they're like, oh, they ingested Tylenol. Well, can you tell me what the bottle says? Because it says pain reliever. So people assume it's Tylenol, but guess what? It's salicylate, or even better, guess what? It's ibuprofen. Salicylate toxicity, that will actually make me turn my light on in the middle of the night, because acute toxicity has the potential for rapid clinical deterioration and mortality. Also, chronic toxicity that we see in the older adult population who take it for their rheumatoid arthritis, their osteoarthritis, is frequently unrecognized. And there's been some pretty cool papers published about that. The clinical toxicity of salicylate, we have CNS, you know, ringing in the ears. That's how we used to dose kids. Again, I'm dating myself. Back in the 70s and 80s, when you develop ringing in your ears, okay, stop escalating the dose. Where I get very concerned is when I hear about a patient who is agitated, delirious, or lethargic, because honestly, that many times is a pre-terminal event, that altered mental status. That's where I get concerned. What do people from salicylate die from? Cerebral edema and herniation. Certainly seizures have been demonstrated to be pre-terminal event with salicylate toxicity. What do we commonly see? Nausea, vomiting. Okay, you can develop hemorrhagic gastritis. And then there's this very interesting non-cardiogenic pulmonary edema that I can probably count on one hand that I've seen, unless it went unrecognized. All right. But what do we see? Hyperpnea, tachypnea. And that can be very subtle in children, especially young children. And so, you know, when I get calls from ER docs who aren't used to seeing kids and they're like, oh, you know, a respiratory rate for a 3-year-old, well, 22, 24, 20, that may be normal. All right. But then, you know, kind of teasing that out. Are they really salicylate toxic? Well, that's where we get a level to help us. This is always a question on the pediatric board exams. Trust me, now that I'm doing my MOC for the billionth time, okay, acid-base disturbances. You know, they're going to give you a case, and what do you see first? Respiratory alkalosis because of the hyperpnea and tachypnea. Then you start seeing metabolic acidosis, and usually they'll give you a blood gas with a mixed respiratory alkalosis and metabolic acidosis. That's usually the question on the test. When you see respiratory acidosis, that's when I get worried. Why? Because they can't compensate anymore. All right. And then they get acidotic really quick, and then the rapid deterioration. You can see electrolyte abnormalities. People aren't aware that even with aspirin poisoning, you can see coagulation abnormalities like you do with acetaminophen. We don't see them as often. And then renal and liver toxicity. Treatment. This is one I do advocate, activated charcoal. We don't use charcoal much more like we did 20 years ago. Perhaps several doses to enhance the elimination Fluid replacement is very important. Alkaline diuresis with bicarbonate therapy, serum alkalinization with bicarbonate therapy to prevent the salicylate ion from crossing in the blood-brain barrier into the brain, and then hemodialysis. And we have criteria of who we recommend for hemodialysis. So that was a quick run through of 3 over-the-counter medications. We still see even in higher numbers, although acetaminophen, it's a little higher, but we've been seeing it for 60 years. And then I'm going to finish up here with Charlie, and he's going to talk to you a little bit about public education, which is one of our primary missions.
Thank you, Dr. Liebelt. It is a pleasure to be here, Miss, in your presence today. As far as public education is concerned, the Arkansas Poison Center tries to answer the call to anyone if they have a request, whatever it may be, that's related to helping prevent poisonings in children, older adults, that sort of thing. We try to be proactive along with being reactive. So if I were to book my calendar now in September for the rest of the year, I would have no more openings for people to start calling, which they will be calling here in the next week or so when the weather starts to cool off. Everyone's been cooped up, and so they're ready to get out and about. And so we want to be responsive to those requests. Through COVID, through all this COVID experience, we've had to pivot. So many of the events that I had planned in 2020 were canceled abruptly, and there was not a lot of notice. I would get a call and it's like, well, oh, Saturdays, we got to cancel. We've got to reschedule, and then we'd get rescheduled again. So there's no excuse for not working at this program because it's so important. Like Dr. Liebelt and Pam were talking about the children that, you know, the increase in overdoses is just staggering. It really is. And that's why I go to pediatric offices all across the state, mainly in Central Arkansas. I was at Children's Hospital some yesterday. You may have seen some of our materials. And I love pediatricians because once they call us, if you haven't, please do so sometime or another. Then they can share how important the Poison Center is, like Dr. Liebelt does in the ER. She promotes us all the time because she's been a managing director and she knows the lives that are saved whenever someone uses a Poison Center, consults them early rather than later. One story is several years ago, a 12-year-old was a late presenter for Tylenol ingestion and didn't do well at all. And this was 3 or 4 days and had buyer's remorse. So that does happen. Seen that over the years. Very sad when that outcome, you can't turn something around, which, you know, the early call though, we can. As far as outreach is concerned, we're trying to branch into new fields. You know, we collaborate with the suicide hotline. You know, suicide prevention awareness is next month in September, and then we'll have Red Ribbon Week in October. And so I'm going to try to piggyback on all of that. Certainly, I've already been working. Last night we had a working meeting trying to plan for some of these events. The Children's Hospital has been a partner with us since I started around 2002, and that was the Safe Kids Coalition. So we did a lot of creative outreach with bike helmets, a vest, you know, for swimming back years ago. But now we're trying to pivot, and we're really trying to work together to address this over-the-counter toxicity problem in youth. And we saw the statistics, and that bears nationwide where it's quite a real problem, and it's not going to, it may not be abating, I'm afraid. As far as public education, I don't do near what I used to do as far as outreach in person. I know that Little Rock School District needs 100 teachers and staff today. And so I dare not call them when they're struggling to staff their class. Some of the kids have no teacher and they're doing a lot of Zoom learning. We do Zoom learning. However, the group participation is not, there's not very many often that are logged into that. As far as our materials, I'll have them out in the back there as you leave. Please avail yourself to some of the materials. And I'll have some out there tomorrow as well. We've done some billboard advertising. Sorry, I haven't been, there we go. Yeah, so I'm trying to get some funding to do this again. We've done it twice before. And here's some of the materials that I've got in the back there that I'm bringing to ERs, PEDS offices, that sort of thing. And if you have any good ideas, my business card is in the back there. You can email me and say, have you thought about this? Because I'm open to suggestions. I've got a couple minutes. If you have any questions for me, Dr. Liebelt or Pam, please, any question. If you've got a good one, I'll bring you a door prize tomorrow. Any at all? It's in the back there.
I think I'm first. So mine's not a question, mine's more of a comment. So we call often to get more of the magnets. And we've taken them to newborn, expectant mom events, things like that. Usually when they look at it, they're like, oh, I'm fine. That was not going to happen to me. So then I use the comment, the people who are going to be watching your child, who are going to be babysitting your child, do they have one of these? And then you start seeing them pick up a bunch of those to take with them. So a lot of people think it would never happen to them, but that's my way of making sure they have one too.
Thank you. That's a great question. Thank you.
What's coverage like in the border cities, like in Texarkana, Fort Smith? If somebody calls from Oklahoma, is there something that routes it by area code, or do you still take it if they call your 1-800 number?
Yeah. That's great.
Several years ago, there was national funding really after 9/11. There is a nationwide 1-800-222-1222. You are routed based on the phone you call from, which works great unless you're on your cell phone and you have a cell phone from which you will not be turned away. Somebody will help you. Typically, if I get a call from somebody in Florida, if it's something that I can manage very easily and doesn't require healthcare intervention at a hospital or doctor's office, I will handle the call. I'll do follow-ups and it works well. If it does require intervention, then I will transfer them to the poison center in their area. So borderline, you're going to reach somebody. And a lot of times we'll get a call from Oklahoma and they're, they have an Oklahoma cell phone, they're routed to Oklahoma, they get transferred to us because they find out they're in Arkansas and they go to Oklahoma hospital because they're Indian Health Service. So it gets a little messy, but we're willing to help anybody.
So if you're a resident from Alabama and you use your cell phone in the ER to call poison control, you're going to go the wrong place. Use the landline.
It's really, Aaron, and it's very loaded. And I'm just going to throw this out there because it's not geo-routed. I've learned all about 911 and now the suicide hotline that's geo-routed. We're trying to get our poison national hotline geo-routed. What it takes to do that is unbelievable. It takes legislation at our national Congress and probably about $50 million.
And it works with some providers and some providers it doesn't.
Like
So.
cell phone, it all depends where your tower is. Like my Alabama phone, I'll get the Alabama poison center because it's a Verizon phone. It's really interesting, but you will always get help, and that's the other thing with some vulnerable populations. There's been research where they're afraid to call the poison center because they're afraid we're reporting, which we are not. We are reporting. Obviously, if we have concerns, we have escalation processes that the specialist will call the medical director on call. about, but that's pretty rare, to be honest. We just want to help them. And but we are not a reporting agency, but we are still deemed, I'm still, as one of the medical directors, to report if I have a concern. But usually they're in the ER and it's taken care of that way, or I have a discussion. Thanks for attending, and please know that we're always here.
And it doesn't have to be a life-threatening emergency. I mean, we get many calls from, a berry or a silica gel packet out of a new purse or whatever. So just
Poison centers save money through preventing kids needing to go in the hospital. If they would call us first for those types of calls, and we're here to reassure parents, and that's also been very interesting, the demographics, the number of calls involving unintentional abductions. Stays about the same as it was 30 years ago. But you bring up a good point about we have so many non-biological parents taking care of children, grandparents, and keeping, the kid I had in the ER the other day, the pill planner, grandma's pill planner. But, educating other groups of people, because poison centers aren't just for children. And we help a lot of older adults with medication errors. They took their morning insulin at night, and we keep them at home. Monitor their glucose doses, because we have pharmacists and nurses who are answering the phones. Anyway, thank you. Yeah.
So, hi everyone. Again, I'm Natalie Burr, pediatrician here in Little Rock. I'm excited to be here in front of a lot of colleagues and mentors, and maybe a little bit intimidated. But I'll move ahead with our presentation. So I have no financial disclosures or conflicts of interest, neither does Sarah. And we'll kind of break this presentation up. She'll do the first part, and then I'll come in. But so the objectives of this presentation, first, we want to identify current trends in oral healthcare utilization of children in Arkansas, and that'll be Sarah's part. Then I will discuss how we want to apply the AAP's recommendations for screening, guidance, and interventions in the general pediatrician's office. And then finally, we'll identify current initiatives both in Arkansas and in the nation that aim to improve pediatric oral health. So I'll pass it off to Sarah. Part.
Okay. Hi, so I'm Sarah Crawford. I'm going to stand on my toes because I feel really short up here. I'm a senior analyst at the Arkansas Center for Health Improvement, which is a nonpartisan independent health policy research center. We were established in 1998 to create an intersection between research and policy in the state. We work to support research and health policy by using our experience in the management and integration of the healthcare data. This is just some information on our mission, values, and vision. So about this project, we completed an analysis and a report on dental care utilization across the state. It was funded by the Delta Dental of Arkansas Foundation, and it supports improved dental care utilization and oral health in Arkansas. We use the Arkansas All Payers Claims Database called the APCD, which includes medical, pharmacy, and dental member records and claim records. The final report was released in June, and you can access the full report from our oral health landing page listed here, and I would encourage you to visit that. There's a lot of information in there, and I'm not going to be able to get to all of it. The goal of this analysis
was to, okay. The goal of this analysis was to provide baseline levels of dental care utilization and related measures in the state. Some of the key measures we looked at included dental coverage and profiles by county, pandemic area utilization for 2019 versus 2020, and the impact of COVID, utilization and preventive dental visits and other service types, utilization of dental care in other non-dental medical settings, active providers per county and ratio to population, fluoride varnish application trends, and utilization of dental services among the uninsured individuals within emergency medical settings. So this slide here, we identified the proportion of Arkansas residents that had evidence of dental coverage in 2019 within the APCD data. We found that most children in the state do have coverage or evidence of dental coverage. Arkansas Kids in the state provides dental coverage to anyone, any children. So I think it's like 85, 87% across the board for children. About half of adults have evidence of coverage, and the proportion covered generally declines with age, as you can see. This map shows the percent of individuals in each county that had evidence of coverage in 2019. We used 2019 as a baseline year for many of our metrics, both because it was the last pre-COVID year, and also because when we started this project, it was the most recent full year of data that we had available. This map shows the proportion of those with dental coverage in the APCD that used any dental services in the year. This is across all ages and coverage types. And you can see that the counties with the highest proportions receiving dental care were in the center, more populated part of the state and in the southwest counties. The county with the highest proportion was Sevier County at 45.1% of individuals using any dental services. This would include routine dental visits, and this is a number that we would like to see increase around the state. So this is just a breakdown of how we grouped dental procedures in our analysis. Diagnostic included things like evaluations and imaging. They would often happen along with preventive procedures, things like teeth cleanings. The restorative category included things like fillings and crowns. Endodontics included root canals, things like that, and periodontics includes dental implants, gum issues, etc. We looked at utilization of any of these services in each of those procedure groups by rural versus urban counties. As you might expect, we found that the use of preventive and diagnostic services were higher in urban counties, and this may have to do at least in part with access to providers. The other services can be more acute, and you can see that the rates are much more similar for those restorative endodontics and periodontal procedures. So this slide shows a comparison of the proportion of covered individuals who used dental services in 2019 versus 2020. So this is a percentage of those who we did have line of sight of coverage for them. In March of 2020, in response to the onset of COVID-19, the Arkansas Department of Health mandated a pause on dental services. Services were allowed to resume later in the spring, but that pause contributed to an overall reduction in the proportion of those who received any dental services in the year 2020. And here's a monthly utilization trend comparison for all dental services in a dental setting between 2019 in blue and 2020 in red. So you can see that dip in the second quarter of 2020 where it drops dramatically starting in March into an April low, starting back up in May and being back to 2019 levels in June. This slide shows dental care use by age groups for preventive services only. So those are like your teeth cleanings for those in our line of sight with dental coverage. We see that the best rates are in the age groups that are 5 to 14, but even there, they aren't that far over half. The 0 to 4 age group appears to be an area of opportunity, as well as 15 to 19. Once they hit adulthood, young adults in their 20s see a big drop in seeking preventive services. And again, these rates are among those who did have dental coverage. This is kind of the same look, but only at any services, not just preventive. So you can see the increases across the board, but in kids 0 to 19, there's about a 4% increase over those just having been seen for preventive care. That jumps to a 7% increase for the 20 to 24 age group, and then it's about 10% of an increase for the rest of adulthood. We know that too many patients seek dental care in emergency departments. We identified individuals with dental coverage who sought care in emergency departments and then looked back from the date of their service to 12 months prior to the date to see how many of those patients had any preventive dental visits in that period of time. For kids, we found a slight majority did not have a preventive visit in the previous 12 months. 51.4%. However, among those with private Medicaid fee-for-service or Medicare Advantage coverage, the vast majority had no evidence of preventive visits in the 12 months prior to their ED visit. So this really underscores the importance of having those routine visits to avoid downstream bad outcomes. We also looked at ED use for dental services among the uninsured and found nearly 4,000 ED visits for 2019 for dental care among this population. Associated charges for those visits were almost 6 million, which translates to a significant amount of potentially uncompensated care for hospitals. This map displays the average charged amount by county for a dental-related ED visit among the uninsured. Switching gears to look at dentist availability and access in the state, we assessed the number of dentists in each county who served at least 20 individual patients in that county in a year. So this is based on the address that the service was provided at. We set the threshold at a really minimum number. 20 patients is not meant to represent a typical full-time patient load, which would be a lot larger than that. We found that in Cleveland and Lafayette counties, no dentist served at least 20 patients. So you can see them in red up here. Many counties had more than 5,000 residents per active dentist by this definition, which is a really low bar. And that's the threshold for a dental provider shortage area as designated by the HPSA. As you know, there are plans for a dental school in Little Rock, and we hope that this will increase the number of dentists practicing in the state. We also looked at the proportion of active dentists who saw any children with Arkansas Kids coverage. These children are all on Medicaid and they all receive dental coverage, and all of them we have line of sight on. We found statewide only 61% of dentists saw any of these patients. Acceptance of this coverage type appears to be lower in some of the urban areas of the state compared to rural areas, possibly because their business is able to be sustainable without the inclusion of those individuals. We looked at fluoride varnish utilization, and it has generally increased since 2014, with the exception of 2020, when overall utilization was down. The black line at the top of this graph is overall utilization, and the other lines represent the two main codes used by dentists to bill for varnish applications. We also looked at varnish applications in medical settings. Legislation was passed around 2014 to enable medical providers to apply fluoride varnish. This is something that the Office of Oral Health and the Arkansas Department of Health has supported. And we see varnish applications in medical settings increasing. The black line is overall utilization, and the other lines represent the main codes used to bill for varnish. You can see that D1206 code in red is trying to be phased out, with the preference being to use the Z293 or 99188 to bill. We also assessed the number of varnish applications per child. The current recommendations are that kids receive 4 or 5 applications a year. However, that's not what seems to be realistic based on what we found in the data. We do see 2/3 of covered kids had at least one varnish application in 2019, with 41% having only one and 25% of kids having had 2 applications in that year. Just before I wrap this up, this slide shows the number of medical providers who submitted claims for at least 20 fluoride varnish applications by specialty type. We see a lot of pediatrics, as you might expect. Arkansas Children's Hospital is one of the larger groups among them. Overall, there were 324 individual medical providers, physicians or nurses, or practices that performed any fluoride varnish applications. So I'll quickly summarize some of the key findings presented in our final report. 54% of Arkansas residents have evidence of dental coverage in the All Payers Claims Database. That's 1.6 million individuals. We found too few individuals seek preventive dental care. COVID-19 dramatically impacted utilization in the state, but utilization mostly returned to pre-COVID baselines by the end of the summer. The counties, or some counties, have a patient to active dentist ratio that is higher than the health provider shortage area thresholds, meaning they don't have enough dentists to service the area. Fluoride varnish applications by both dental and medical providers have generally increased since 2013. Many individuals seek dental care in medical settings, including emergency departments. Utilization was lower among individuals who did have preventive care in the previous year. And many individuals with no insurance sought dental care in ED settings associated with annual charges totaling almost $6 million. There are a few areas where we plan to continue our research in this space. We'd like to pursue some more in-depth research on provider availability and access, linkage to additional social determinants data, further linkage with medical claims to assess impact of dental care and oral health on subsequent overall health. And then analysis of reimbursement and benefit limits and costs. There are some insurers that have limits on the amount of charges you can do for dental related services. So seeing if people drop off after they hit those limits. Ongoing collaborative patient education efforts are needed to reinforce the value of routine dentist visits. Future analyses would be strengthened also if additional data sources were made available. There's a lot of public health dental services, temporary pop-up clinics, non-claims based dental care, stuff like that. But it's been a pleasure to tell you all about this, and I'll let Dr. Burr back.
Thank you so much for some of that just baseline data. One of the things I wanted to point out is, it looks like we've got pretty good dental coverage among our children in the state. 80 to 88%, depending on the age of kids. But then when you look at that utilization, we're looking somewhere around that 0 to 4 age group, which we have as general pediatricians an opportunity to see a lot. That's pretty low utilization there, somewhere in the 30% range. So what can we do to try and increase that? So the second objective is going to be applying the AAP recommendations for things like screening, guidance, and interventions. And so I'll go just a little bit more into that. So why does the general pediatrician even have a role in this? Why do we care? Why is it important? So first off, dental caries is the most common chronic disease of childhood in the United States. Shouldn't be too surprising, right? Whether or not we talk about it a lot in our office, we look in children's mouths all the time. We'll see these cavities, we'll see signs of decay. As we know, poor oral health has an effect on many aspects of child well-being. So nutrition, can they eat healthy food? Is it affecting their speech or their speech development? Of course, self-esteem, and then school attendance and performance. If children are hurting, they can't pay attention. If children are having an infection in their mouth, they may not go to school. We have an opportunity to discuss oral health with caregivers and families guess I could take the mask off. Most children visit their pediatrician 10 or more times during the first 3 years of life. That's well visits alone. That's not our sick visits. That doesn't even represent all of the opportunities we have to see families. And of course, you know, what do we do as pediatricians? We do education. So oral health education, oral health screening, and then fluoride varnish application and facilitating referrals to dental homes for our families. So this is a pretty wordy slide, and we'll go into some more detail on some of these specific numbers, but it is the AAP policy statement on maintaining and improving the oral health of young children. So I did want to have it up here in its entirety. So the first thing is to administer an oral health risk assessment periodically to all children, not just children we deem high risk. We'll talk a little bit more about that. Secondly, include anticipatory guidance for oral health as a part of your patient counseling. And number 3 rolls into that. So you want to counsel people to reduce frequency of exposure to sugars and food and drinks. I think we see that all the time. People look at us like maybe we've grown a second head if we tell them juice is bad. When you say, you know, actually, no, the juice is not good. It's got a lot of sugar in it. We really shouldn't be doing that. So I think just letting people know that information, encouraging parents to brush a child's teeth as soon as teeth emerge, advising parents to monitor that brushing until, you know, it says here 8 years of age, but you know, your child best, right? Is your child brushing all surfaces of the teeth? Are they actually brushing their teeth when they told you they were? Next is, and we'll talk about this a little more in detail, refer to the AAP clinical report on fluoride use for administration and supplementation decisions. 7, build and maintain collaborative relationships with local dentists. So when you do have a child in your office that has an urgent need, do you have a dentist locally that you know will see young children that can maybe get this child in quickly and help them? And then 8, recommend that every child has a dental home by 1 year of age. I think even still, we think, wow, that seems really young, but that's actually the recommendation, and what we see improves these outcomes for children. So the oral health risk assessment, I think, yeah, y'all can see that pretty well. So this is a tool actually provided by the AAP, and it's to help in implementation of this risk assessment that we're asked to do. So you can see the 3 columns. You have your risk factors, your protective factors, and your clinical findings. So that's actually what you see on exam. So as far as risk factors, you can see some of these have the little yellow triangle by them or the caution sign. If one of those is checked, then the child is automatically high risk. And so if you look, the first one right there is mother or primary caregiver with active decay in the past 12 months. That's a lot of our patients. And then just other risk factors showed, is mom or primary caregiver not have a dentist? Is the child using a bottle or continuous sippy cup use with something besides water in between meals? Are they snacking a lot between meals? Special healthcare needs. So, you know, that's not just our children as we think of as our complex care patients, maybe they're on medications to reduce secretions that affects oral health. That could also be our asthma patients. So there are studies that show that use of inhaled corticosteroids, especially if children aren't brushing teeth, washing mouth out afterwards, can have a negative impact on dental health. Patients on ADHD medications that dry their mouth out all day long, you know, saliva has a protective factor, so this can also have a negative impact. And then just by being Medicaid eligible, that socioeconomic status increases risk for poor outcomes in dental health. Protective factors are what you might expect. So does the child have a dentist? Do they drink fluoridated water? Are they getting fluoride varnish? And are their teeth being brushed twice a day? And then you have your clinical findings. So what do you see on exam? This isn't anything too in-depth, right? They're not asking us to do a dental exam. This is strictly a screening. But do we see white spots? Do we see visible decay? Do children already have fillings present? If so, then they're automatically high risk. Other things that you look for, you know, are the gums swollen or unhappy? Do the child have teeth? Do they look healthy? Is there plaque there? And then down at the bottom, it even gives you an assessment and plan where you choose, are they low or high risk? What did you do? Hopefully you did anticipatory guidance, fluoride varnish if it was needed, and hopefully you made a referral if they weren't already referred to a dental home. And then it has some self-management goals, things that hopefully we're already talking to families about. So if you look at the age for this, it should actually be performed at 6 and 9 months of age. So this is really around the time when teeth are first erupting even. We should be talking about these things before children even have teeth. Should be done at subsequent well visits if children don't have a dental home. But again, the goal is for children to have a dental home by 1 year of age. And I've even had it, seen in the AAP where it's recommended to, if you do this oral health risk assessment tool, to go ahead and fax it with the referral to the dental home, because it's information that's good for a dentist to have. So a little bit about fluoride. So just first off, why is fluoride important? Well, our mouths contain bacteria. Bacteria combines with the sugars and the foods we eat. This produces acid, which can hurt our enamel. Fluoride actually helps teeth in a number of ways. It will enhance the remineralization of enamel and also inhibits demineralization. So just again, this is another AAP clinical report or policy statement about what we should do as pediatricians. We should know how to assess risk. We talked about that. Recommend use of fluoridated toothpaste at eruption of the first tooth. So not only should teeth be getting brushed as soon as they come up, but with fluoridated toothpaste. Know how to determine concentration of fluoride, and we'll talk a little bit about supplementation. Apply fluoride varnish when appropriate and use the correct code. And then advocate for water fluoridation in the local community. So I don't think as pediatricians, that's something we often think about, but we advocate for lots of things for our patients. And water fluoridation is a huge leap forwards in public health as far as protecting teeth. And then the final one is pretty specific, but it is listed in the statement, so we'll touch on it. But understand indications for silver diamine fluoride and be able to recognize teeth that have been treated with it. So as far as fluoride sources, the first one we usually think of is water. So 0.7 parts per million is the optimal amount. There used to be a range for this of like 0.7 to 1.2 because they thought maybe children in warmer climates drank more water. That didn't really end up being true. So 0.7 is the optimal amount. And I'll talk a little bit about My Water's fluoride tool so you can actually look in your community locally and see how much fluoride is in your patient's drinking water. Oral supplementation is recommended if primary water supply is deficient in fluoride, and we'll talk a little bit more about that. Toothpaste. So I like to have this graphic on here because when you look at a box of toothpaste, you see this huge swoosh of toothpaste on there. That's not an appropriate amount. And if you let a child do their own toothpaste, they will probably get a huge amount because it tastes like bubble gum or something else that children like. So the correct amount for a child under 3 years is a dusting or a little smear or a grain of rice. And then for children over 3 years that can spit toothpaste out, it's more like the size of a pea. Fluoride varnish, which we'll talk more about. And then mouthwashes, prescription toothpaste, that's something that's typically done by a dental professional. We won't touch as much on that, but those are other sources. So this is actually, I just took screenshots from the CDC My Water's fluoride tool. I just kind of picked a random county. My family's from Chico County. So I pulled that one and you can see there that most of them say yes, but then if you look at Dermot Waterworks, it says no, it's not fluoridated. And then the next page over shows what the fluoride concentration actually is and how many people are served by that water supply. So you can get an idea of, is this maybe a patient that needs some supplementation of fluoride? So fluoride supplementation guidelines. So we only want to supplement fluoride if the primary source of water is not fluoridated, and we've assessed all potential sources of fluoride that a child might be getting, and we still feel like they're going to be deficient. So, we really need to think about, okay, is a child in daycare all day and their formula at daycare is being made with water, maybe that's been fluoridated? Is the family, getting fluoridated water from somewhere else? Well water definitely should be tested before prescribing any kind of supplements. Well water is not all deficient in fluoride. And the reason for this is the risk of fluorosis, which I'll talk about in the next slide, is high if a child drinks fluoridated water and is given supplements. There's just a little chart here that was taken from that AAP policy that just talks about how to supplement fluoride. For those of us here in Central Arkansas and a lot of the state, it's not something we have to think about very much, but in rural areas, it is. So fluorosis is a cosmetic condition. It is caused by excess ingestion of fluoride before the eruption of permanent teeth. Children are at really high risk for this, especially from like 1.5 to 3 years of age, but really at any point before the eruption of permanent teeth. So you can see here, you've got normal teeth. Usually what we see is mild fluorosis, and you see that a lot on people where they've just got the white lines right there on the bottom. And then of course, the moderate and severe have a little bit more of the brown. This is typically due to high levels, whether it's in tap water, excess toothpaste, maybe oral supplements were given when they really didn't need to be. And then children and adults who consume a typical diet, drink fluoridated water, and use optimally fluoridated dental products are not going to have this problem. Again, this is something that in more metropolitan areas, you don't have to talk about much, but I've learned just in the last year from being in this oral health advocate role that fluoride can actually be a really politically charged big debate in communities about whether or not to fluoridate water. And so I think this is another one of those opportunities for us as pediatricians to, be able to state facts and explain what fluoride is actually for. So fluoride varnish, this is something we can actually do in the pediatric office to help improve children's oral health. So the supplies are pretty simple. You just need some gauze pads. I like to use the non-woven ones because woven ones snag on kids' teeth. I learned that the hard way. Some varnish and a brush. So you could just, some people just get a big jar of varnish and have a bunch of brushes. I like these little, I guess I call them little single serve kits where you just open it up and it's got a brush and a little well of fluoride varnish, and then some instructions for the family. So, children shouldn't have hot or sticky foods for about 6 hours afterwards. They don't need to go home and brush their teeth right after. Application every 3 to 6 months. It really depends on, again, if those children are high risk or low risk. So, typical private insurance and Medicaid, as far as with the medical code, is only going to pay for it every 6 months. Okay. Again, if children are high risk, they need to be seeing a dentist anyways. But as far as reimbursement, so the cost for the little applicators, it comes out to about $1 a piece. For your reimbursement, Medicaid reimburses almost $20. Private insurance, anywhere from $10 to $19, depending on the insurance. And I did list the code here. So as far as actually applying the fluoride varnish, this position here of the practitioner is what I prefer to use, unless I've got an older kid that I know is going to be just perfectly compliant. But I have the parents sit with the child on their lap, legs around their waist, and I have them lay the child's head in my lap. I typically will have the parents hold the hands because the varnish is really sticky and kids will try and, grab it, get their hands everywhere, and it can be pretty messy. So you just use the gauze, you dry their teeth off. If there's any like food or goldfish or anything stuck on their teeth, go ahead and get that off, and then just apply a thin layer of the varnish. So you don't need to like gob it up on there. I mean, it's prescription strength fluoride. So, you get a thin layer. I did this picture here. The most varnish, or at least what I get, is not yellow, although it sometimes is, but the picture shows here how they are trying to hit all the surfaces of the teeth. You do your best. Sometimes children are not really compliant with this, but so that's how you apply it. Just a word about the silver diamine fluoride, since it was included in that policy report. So it's a low-cost liquid solution that's painted on cavitated lesions to arrest decay. This is totally at the dentist's discretion. This is something dentists may choose to do for whatever reason. Maybe they need a non-surgical technique. Maybe there's issues with anesthesia or in other reasons why they can't do traditional restorative dental care at that time. But I think it's important because if you aren't aware of this and you look and see this in a child's mouth, instead of thinking, oh my gosh, this is horrible, horrible decay, you might want to ask the parents, oh, this is, did they paint something on your child's teeth for cavities? Maybe that's what you're looking at. Some people don't want to do it because it turns the lesions black. So there is aesthetic concern there for families. So moving on just to our third objective. So identifying current initiatives here in Arkansas and in the nation that aim to improve pediatric oral health. So as always, the AAP is a really great tool for us as general pediatricians. This is not just for people who are members of the section on oral health. This is tools available to any of us. So some of these we'll talk a little bit more in detail about. Guidelines. I talked about the two main ones. There are some more specific ones as far as children with special healthcare needs and oral injury. And some of those, there are some practice tools that are useful for us in our clinics. Advocacy, typically, again, we're talking about water fluoridation and like payment reimbursement advocacy. If we have certain insurance payers that are not reimbursing for fluoride or other things, I mean, like risk assessment tools, that's those, oral health risk assessments are not reimbursed in Arkansas and a couple other states they are. The Protecting All Children's Teeth curriculum is an educational curriculum I'll touch on briefly, and then Protect Tiny Teeth and Brush Book Bed are actually things you can implement in your office. So oral health practice tools. So I did not list them all. There's actually more than this listed on the website, but these are some of the ones that I think are really useful. So oral health practice models. So we're talking about, PDSA cycles. How did practices actually implement, whether it was oral health screening, risk assessment, fluoride varnish, how is this actually implemented in your clinic? EHR templates, whether it's for fluoride varnish or risk assessment, fluoride varnish resources, so where to buy it. Training videos, we have those for screening exams. We also have those for fluoride varnish, water fluoridation resources and info. Again, that links you to CDC and some fluoride supplementation info. We all know Bright Futures. So Bright Futures Oral Health Pocket Guide has some good tools there. Oral Health Risk Assessment Tool, we already talked about. Family education resources, whether it's posters and flyers to go in your clinic. The parent website for the AAP, healthychildren.org, always has a wealth of information. A dental referral resource sheet to facilitate referrals, and then billing and payment resources and advocacy are just some of the things offered. And again, you don't have to be a member of this section on oral health. So real briefly, I'll just talk about the Protecting All Children's Teeth. So this is a free online curriculum for educators. So anyone that educates students, or, even I'm in private practice, I don't have students, but I used this for a noon webinar a month or two ago for the AAP, and just kind of took a couple of these PowerPoints on basic, dental oral health topics. And it also has a post test. It has an instructor guide. I mean, it really takes you step by step through how to use the presentation, and they're there and they're free for us to use. The Protect Tiny Teeth Toolkit is it's more for your office. So it's aimed more at expectant mothers, but also infants. Of course, in the pediatrician's office, we see lots of expectant mothers there with their older children. So this is still applicable for us. It kind of lists all of the things that it will give you, but I mean, printable posters and brochures that you can personalize with your clinic info, referral forms. I really like the social media toolkits that the AAP provides for different things. If you have an active social media for your office, just saying, I mean, they're right there. You can just say, this is Oral Health Week, and just they've already got the content for you. You just put something new out every day. And again, these can be personalized to your clinic. You can put, these posters by the way stations in the waiting room, in your clinic exam rooms, somewhere where people are sitting and waiting for you, where they might look up and see it. This one's my favorite. So Brush Book Bed. So this combines things that we typically talk about as general pediatricians. So safe sleep and regular nighttime routine, early literacy, so reading together, and then oral health. So the 3 B's, brush, book, bed. Children should have their teeth brushed, read a book with your child, and then put them to bed. When we're talking about safe sleep, we say, of course, on their back, and talk about all those things. But it's really geared towards that 6 months to 6 years of age. It has, of course, an implementation guide, posters. There's little bookmarks, but I really like the stickers, especially if you're a clinic that has reach out and read. Or a clinic that just provides books. Maybe you have a different grant, or you provide books for your patients. Can you print out the stickers and stick them in there? And maybe they remember that message of Brush Book Bed that you talked about before they put their child down to sleep. So just switching gears to some of the more local things that we have. So school-based, so we know we have a lot of school-based health clinics in the state, or you may not know, but we do. And over 20 of them offer some dental services. So you can kind of look here at the list and see, is there someone in my local area that's providing this? So they partner with local dental providers to provide these services. And sometimes, or oftentimes, they even provide dental services for maybe staff at the school, family members, or community members. So if you're out in the rural part of the state and you see here, oh, that town's right near me, well, then you've got a dental partner close to you. You've got someone that cares about, children's dental health enough to take time out of their day and go to a school and take care of children that may or may not even be able to pay for the services. They tend to provide, an array of services. It really just depends on the provider. But one thing that research has shown is, yes, there are issues with access to care, but also as far as getting people to get the care, you really need to get to where the people are. And thankfully, most children are in school. And so getting to the schools is something that's been really successful. So on that same note, of course, Arkansas Children's is going to have some outreach programs. They have mobile dental clinics. So these 4 vans that they have can do anything. They can do teeth cleanings to a root canal, all within this mobile dental clinic. They have over 2,700 annual visits. They have their school-based programs. So this is their dental sealant program. I really didn't talk much about dental sealants, but this is basically a sealant that goes over the permanent molars of children to protect them from cavities and kind of those cracks and fissures of molars where children get a lot of cavities as they get older and have those. And it can, if done correctly, can prevent a lot of them or virtually all of the cavities in those areas. And of course, they do education for oral care on students, oral health care. They have a fixed base clinic, and that's over at Wakefield Elementary, but they serve a lot of children in different Little Rock School District elementary schools. So Delta Dental of Arkansas Foundation, of course, we've seen they were a sponsor for this conference. They do a ton throughout the state. If you have an idea for a project in your community, I would say, reach out to them, talk about, how you could partner with them. So I have here listed their mission. They focus on building partnerships with existing nonprofits, agencies, schools with a focus on preventative health. So preventing those costly, severe outcomes in the future. They provide lots of different grants. One that I specifically talked about or mentioned here was Super Smiles at School. So again, it's a mini grants program. It's school-based for oral health education. They donate lots of supplies. You see the oral health kits that, you get handed out at events like this one, toothbrushes, mouth guards, educational materials. They're great partners. And one of my favorites I saved for last. So the Paint a Smile program is through the Arkansas Department of Health. This is really important for us as general pediatricians in private practice. So they provide free on-site training for fluoride varnish application. So they will provide a starter kit, a billing education and workflow management. So my clinic did this a couple of years ago and it was great. They sent someone out. They were there just during lunch. They did a PowerPoint presentation. They talked to us about workflow. How would you do this if you're going to have your MA or your LPN do it versus if you're doing it yourself? This is how you should bill for it. This is who will pay for it and the couple that won't pay for it. So their goals are to close the gaps that exist for kids who don't have access to dental care. Of course, reduce the risk of dental caries. Fluoride varnish is going to do that. Initiate referrals to dental homes and then educate caregivers about tooth decay and prevention. And so one thing I'll say, when I'm putting fluoride varnish on a child's teeth, I'm not just saying, it's a little more than just saying, hey, brush your kid's teeth twice a day. I mean, they're seeing that you're actually doing an intervention to try and put something on the child's teeth to prevent that active decay. And you're saying you need to go see a dentist. I mean, this is important enough. I know your child only has 4 teeth, but they're important enough that I'm going to treat them and they need to go ahead and see a dentist at this time. And it kind of hits home for people. Okay, so the last slide is just that in this new role as the oral health advocate, I really, really want people's feedback. I feel like I have maybe a decent grasp on what it's like in private practice in Little Rock for this, where you could throw a rock and hit a dentist that's going to see children under 4 years of age. I don't know that that's the case in the rest of the state. What are really the barriers that general pediatricians are encountering? Is it, I don't have time to talk about this? Is it, the fluoride's not worth it to me. The reimbursement's not good enough for the time I put in to do it. What barriers are there for patients and families? Is it nutrition? Do we need to talk about, why, if they're getting supplemental, help with groceries or whatever, why is it all this juice? Why is it, why is this available? Is it transportation to appointments? Is it access? Is it, I don't have a dentist within 100 miles that will touch a child that's under 3 years of age? What can we do with our partners that are there to help improve that dental access, improve that number of those 0 to 4-year-olds that are actually using their dental coverage? And then these are my references if anybody's interested. And that is the end of my presentation. Okay. Both mine.
Thank you so much. That was very informative. And if anybody has any questions, one thing I wanted to ask you, or a couple of questions about the fluoride varnish. Sarah mentioned that it's recommended to do it more than twice a year, but I was wondering about reimbursement for that. And then does fluoride varnish cause fluorosis? And then if someone wants to implement a program within their clinic where they start to do the varnish, is it required for them to have the training? How do they go about making that happen?
Sure. So I think the first question was, is it reimbursed? So the medical code is not reimbursed more than once every 6 months. So some children are higher risk and they need it, up to 4 or some, more times, 4 times a year. It's only going to be reimbursed the medical code every 6 months or twice a year. Some that may vary some with some private insurance payers. Now, it does not, if you do the medical code, it doesn't mean the dental code doesn't get reimbursed. So you're not double dipping, you're not taking something away from the dentist. So if a child sees you and then 4 months later they see their dentist and the dentist applies varnish, the child's high risk, they needed it, they're still going to get paid too. So that's one thing where you're not really getting, into theirs. As far as the training, yes. So for Medicaid, you need to be certified. I personally think the easiest way, well, there's an online training you can do. You can get it done that way. I think it's really nice to have it done through the health department because also once they finish that training, you sign a paper and they send in your certificate and you're certified and they take care of that for you, which is really nice. And also they give you like a free kit with stuff. And then what was the other question? The fluorosis. So if used correctly, no. So if one thing I'll say, just like I said, this is prescription strength fluoride. So don't just get a big glob of it and just throw it in the kid's mouth. I mean, you need a small, thin layer of it. Sometimes I'll even, if I get a bunch on the brush, I have gloves on because I'm in the kid's mouth. I'll paint some of it on my glove before then putting it on the teeth. So no, if you're using, again, those optimally fluoridated dental products and not using too much, it will not cause fluorosis. What's that?
Thanks, Dr. Burr. Thank you so much for sharing all this good information. And I will just attest to her ability to work fluoride varnish into a 12 or 15-month visit, or maybe both, I can't remember. But she did an awesome job of that and it was super easy, even with a wriggly little baby. So thank you for that. And I wanted to also just, if y'all haven't yet, point out the folks from the health department over here. If y'all will wave your hands, if you want to talk with anyone, they do not have a booth because we had to shut down our booths because of COVID policies at UAMS. But if you would like to talk, they registered for the conference instead. So if you'd like to talk with them about Paint a Smile or anything, they are over there. And I know they came to your clinic and helped, right? And helped. Yeah. So I do have a question though. And one of the things I think about a lot in my role at the Arkansas chapter of the AAP is about practice transformation and MOC Part 4 and some of the things that can help you all get something out of, in addition to just, improving your practice, but get something out of it as well. Can you talk about, are there any already kind of put together MOC Part 4 projects? Are there any things that we can do as a chapter to help support the broad take-up of this? And then also, what has your experience been within your own practice of helping your colleagues also pick this up?
So
I'm sitting by one.
Yeah, to answer your question about the MOC Part 4, yes. And when I was trying to get this presentation done, I was like, Matt, we have to talk later. But Mr. Vermillion over at Delta Dental has mentioned, because there is already a put together, it's basically a training on oral health screening, dental referral processes, and, fluoride varnish or anticipatory guidance. So there is a project that has been done in other states that we're hoping to bring here that would offer some MOC Part 4 credit. And it would basically be a training where hopefully, this is all in its infancy, but could, come to your clinic and potentially do the training and you could get that MOC Part 4 credit. And then you said, as far as implementing in my own, so we got, and I joined the practice, I guess, 5 years ago. And I actually was trained in residency to apply fluoride varnish, thanks to Carla. It was her project, but I was one of the first classes of residents that was actually trained to do that. And so when I came in, I was like, oh, well, that I think they were kind of doing it, but maybe hadn't done it in a little while. And so I feel like when we had the Department of Health come, it kind of revamped things. And we even talked about, hey, let's kind of talk about a schedule. Do we want to do this at, 12, 18 to, until a child is established in a dental home. So we do have some ages where we try to do it. I have, we all kind of like to have our exam rooms differently, but I have varnish in all my exam rooms. And it's just like anything else, I'm talking about all the things I talk about at a typical 1-year-old visit. And I'm like, oh, if I try to talk about getting into a dental home at 6 or 9 months. And if at a year they haven't seen a dentist yet, then I say, okay, well, let's go ahead and do the fluoride varnish. And it just rolls right into it. I have the parent put the child in their lap, they lay them down, zip, zip, it's done. And that's also an opportunity for me to actually look at the teeth and point out, hey, mom, dad, do you see these white spots on here? This is kind of why we were talking about, about the juice in the bottle. And thankfully, some of this early decay can actually be reversible. And here's how. And so it opens up an opportunity for us to do an exam, but also to talk to the parents about what we're finding.
All right, thanks. Just a second. Oh, yeah, I was curious, for those of you who are in primary care or do clinic, how many people are doing varnish now? Okay, good. And then how many people are in a practice where they could be doing varnish and aren't, and, are in private practice or in primary care and could benefit from learning how to do that? So that might be some helpful information. It's about just a handful of people, but I think, knowing that there are opportunities out there and that people are interested in doing that in their practices.
Quick question. That was great, Natalie. I think you referred many times to referral to a dental home, but I don't think insurance requires a formal referral, but a recommendation. And so in our clinic, we have lists of local dentists and include in that list those who take who have Spanish interpreters or Spanish providers. So that was just wonderful.
Yeah, we've definitely, there's different ways. And in that AAP practice tools, it talks about dental resource referral forms. So some practices, I will tell you just another board or group that I'm on. I mean, dentists, because of the same things we have, as far as no-shows, they don't necessarily want your referral department to call and make the appointment for the patient. People are a lot more likely to show if they make their own appointment. Some of the providers, so for our kids, they get their dental care through there's MCNA and there's Delta Dental. And actually MCNA, I don't have as much information about, but Delta Dental, I mean, they have a program where you can still send a referral basically to them, and they do a 3-way call with the parent and the dental office. I mean, it's like total closed loop communication, trying to make sure that the people know about the appointment. And they'll, they send reminders. I mean, there's a lot of resources out there that I just didn't even realize. But yes, people don't need a referral. It's more, sometimes facilitating that, or even dental offices sometimes are fine with, send us the demographics on a patient and let us reach out to them. Just doing that one extra step. But yeah, that's true. They don't have to have one.
Natalie, I wanted to add a point that it is very easy to get trained in this. The online module that she mentioned, it's very easy to train on that and get your certificates. We do it every year for our residents when they start orientation. So they all go through this online module, get certified, and then we start helping them do the fluoride. So it's not very hard. For those of you who want to implement in your practice, just go to the online module, and then you can print your certificates and you can just get started. So it's very easy.
Thanks.
Oh, sorry. I have one more question, or actually comment. Thank you for mentioning the benefits of water fluoridation. The good news is about 87% of all Arkansans have access to adequately, optimally fluoridated water. I will ask if there's any pediatricians from the Boone, Marion, Newton, or Searcy County areas, please come have a chat with us. We're a little deficient in that area as far as water fluoridation goes. So we'd love to brainstorm ways to kind of talk about the benefits of fluoride and positive impact fluoride can have.
That was really good information and hopefully people can take some of that back to their practices. I think we go ahead and just move on to our next speaker so that we can kind of just keep things flowing. Our next talk is being brought to us by Dr. Gwen White, who I have had the opportunity to meet over the last couple of years, but only in person one time before today, because she is the treasurer of our board for our Arkansas chapter of the AAP. Gwen has trained and worked in private practice in Batesville, where I think you still go there some too, right? But now is currently involved in the newborns there at Arkansas Children's and UMS. Okay, didn't totally butcher that. And she's going to be talking to us today. The title of her talk is Historical and Contemporary Racism in Children's Health Care in Arkansas. That does not look right. Let's see. Okay, I just needed to do one more click. Okay, so let's welcome Gwen White. Thank you.
Good afternoon, everybody. How are y'all doing today? Good. So I'm excited to be here and we're going to get started. Let's see. I can figure out how to work things here. Mouse. Okay, there we go. All right. So I have no disclosures at all. But I do have a quick disclaimer, and that is that this is a work in progress. So just to give you a little bit of background information on this project, back in 2020, the board of the American Academy of Pediatrics issued a journal article where they did a public apology, where they apologized for preventing two men from being inducted into the AAP. These two men were prevented from being inducted because they were Black men. And so that letter was widely circulated and it was utilized as in part of the DEI efforts so that sorry, I lost my train of thought. So it was utilized in the DEI efforts in an effort to try to work towards dismantling racism. And so the first step in those efforts is truth telling, and that was part of the truth telling method that they used. And so what they encouraged us to do is go back to individual chapters and do a similar thing. Look within your chapters, work to try to increase diversity and inclusion, and by doing so, telling your truth. And so I was approached by Dr. Gary Wheeler. For those of you who do not know him, he is a retired pediatric infectious disease doctor from ACH and UAMS. He's a former director at the Arkansas Department of Public Health and former president of the state AAP chapter. And so Gary approached me. He's a huge advocate for children and does a lot of stuff on the national level and said, we need to work towards doing this. And so let's work on a project. And so we started to look at the data and try to collect things. And what we quickly realized was that there's a paucity of data that talks about racism in the state of Arkansas. But we are very, very fortunate that we still have people that are alive that can give us firsthand history. So we've put together some data. We have started interviewing individuals throughout the state that have either lived here for an extended period of time, that grew up through it, or have worked in it. And we have started to put together this project. And so our goal of this is to, at some point in the next couple of months, put together a formal paper, which really outlines this history based off of the interviews that we've done, based off of the research that we've done. But this is just a beginning of it. And so I want to say that the topic that we're discussing today is a very sensitive topic, and it's a topic that we could go on and spend a weeks-long seminar talking about. I don't plan on getting into super detailed information right now. I just hope that I can give you a little overview of information, hopefully pique your interest enough that will encourage you to go and try to get more information, and hopefully give you some information that will maybe help to change the way you interact with people on a daily basis. So the objectives for today, number one, we're going to define racism and discuss the different types of racism that exist. We're going to provide a history of racism here in the United States. introduce the history of racism in the state of Arkansas, try to discuss pertinent disparities that still exist in healthcare in Arkansas, and then we're going to articulate some methods of dismantling racism. So briefly, a history of racism. First of all, I think it's important to define some things. So when we define the word racism, it is defined as prejudice, discrimination, or antagonism directed against a person or people on the basis of their membership in a particular racial or ethnic group. Typically, this is one that's going to be a minority or marginalized. I think it's important that we realize that race is a social construct. It's not genetic. We are 99% exactly the same, everyone in this room. There's only 1% difference in our genome. So race is a social construct that was created specifically to keep one group higher and oppress another group. And we need to make sure that we think about that as we move forward. So racism, the concept of racism really first came about in the mid 1400s when Pope Nicholas V issued a decree that, that basically declared that all of Portugal should go forward and conquer anyone that was non-Christian, non-European. It was the Christian thing to do. We had to spread the doctrine of Christ, and this is what we're going to do. That continued on, encouraged throughout Europe, and by the 1600s, slaves had been brought over to what is now known as America. So here in America, before 1619, the Spanish had come in, indigenous people had been moved out. The ones that were still left in the areas were treated as indentured servants, and any Africans that had been brought over were also treated as indentured servants. That means that they could earn their right to freedom. So they'd work for a little bit, they'd make money, they can get freeman status. In 1619, for the first time, English men brought over 20 Angolan Africans, and that was the first time that there was actual trade that was done. So these human lives are being given for food and for supplies. And so that is the establishment of the slave trade here in what we now know as America, but in North America. Over the course of the next 100 years, there was an elimination of Black freeman status because of formal slavery laws that came into play. And that created the chattel slavery system, which we all know about. Over the course of the next 100 years, there's a dramatic increase in slave importation. We needed to support the tobacco and the cotton agriculture, build up the economy. And that continued until the late 1800s when the Civil War occurred. And then there was a formal end of slavery with the Emancipation Proclamation in the 13th Amendment. Now, there was a brief period of time after that. So from 1865 to 1877, we had this wonderful period of Reconstruction. And during this time, Blacks were able to become congresspeople and lawyers and doctors and do everything. And then it was allowed by law. And it was this very, very wonderful time frame, but it was brief. And after that 12-year time frame, a lot of laws came into existence. The KKK was created. Jim Crow laws came into existence. We basically went back to state-sanctioned terrorism. And Blacks were again oppressed within our country. So if you think about it, from 1619 until 1968, when the most recent Fair Housing Act was enacted, legally, there was oppression that was allowed by our government for a certain group of people. So the first 349 years of the existence here, there's an oppressed people. It's been the last 54 years that we've had pure freedom in the eyes of the law, okay? So when we think about where we are as a nation and as a group, it really kind of makes sense if you look at the time frames. 54 years that we've been working towards true freedom under the eyes of the law. So that's a little bit of background history. Now let's talk about the types of racism, because when we think of racism, most people think about personal racism or intentional racism. We think about what happened around the corner over at Central High School, the Little Rock 9. So we had 9 high school students that were coming to integrate Central High School. They were surrounded by throngs of mobs of adults that were yelling obscenities, throwing things at them, making sure that they knew that they weren't welcome. The governor of the great state of Arkansas called in the National Guard to keep these kids from entering the high school. We may think about situations like Emmett Till. For those of you who have never heard this story, he was a 14-year-old young man that came down from Chicago to visit his family in Mississippi. He was accused of whistling at a white woman. That evening, her husband came with a few of his friends, removed him from the home, beat him, drowned him. His body resurfaced a few days later, once his mother was able to come and get his body, she actually required an open casket. This is actually one of the first, what we would consider viral moments in history, because this was the first time that print media was able to see the Jim Crow South. And so this was published in magazines, both nationally and internationally, and it became a black eye for the United States. Sometimes you may think about the Tuskegee syphilis trial. For those of you who are not familiar with that, it occurred from 1932 to 1972, and it was run by the United States Public Health Service and the CDC. Basically, during this trial, 400 African-American men with known syphilis were brought in to be studied to see the effects of syphilis on their bodies. Now, during this time frame in the early 1940s, penicillin was invented. We know that penicillin worked to treat syphilis, and so the syphilis rates across the country plummeted. However, these men were refused treatment with the specific objective of seeing what primary, secondary, and tertiary syphilis look like. And so our government sanctioned the study, and it was not shut down until 1972 when these men's lives were lost. This was the initiative behind, a big impetus behind the IRB that we use today. And then you may think of more recent things, like back in June of 2015, when Dylan Roof went into a church Bible study at Emmanuel AME Church and killed 9 churchgoers. So these are those intentional racism. It's those acts that we see, that we look at, we're like, this is evil, this is wrong. But there are other types of racism that we have to be aware of. Systemic or structural racism. What this includes are tax policies. So, for example, throughout history, when we look at our tax records, gifts and inheritance and property sales are typically not taxed. There are tax incentives that are given for 401ks and other retirement plans. There are tax incentives that are given for mortgage interest rates, but not a similar thing given for rental properties. And as a result, this is going to disproportionately impact Black Americans, because Black Americans are much more, and minorities in general, are much less likely to have jobs that have 401k access. They're much less likely to have home ownership. We look at redlining in housing. Redlining is a policy that was established back in the 1930s, where the federal government housing authority literally drew on maps and created red lines on the maps and said that these areas that are typically diverse neighborhoods, Black neighborhoods, are not allowed to, are considered at-risk areas. And so as a result, we will not give you home mortgage loans for them. If you're able to get a home mortgage loan, even if you are a similar candidate to a white person, your rates would typically be 5 to 10 times higher. If you were able to get that 5 to 10 times higher rate, then the insurance companies would say, well, you live in a high-risk area, so we're not going to give you insurance for that. And so it was an intentional cycle by the government to keep minorities from home ownership. Those same redlining principles continue today in credit card lenders, within student loan lenders. Most recently, Sallie Mae was actually sued back in 2007. It was settled out of court in 2011, where basically they showed that they had discriminatory practices for Hispanic and Black Americans that were trying to apply for private loans. They intentionally would not allow them to get certain loans, or would raise the interest rates simply based on race. And so this was settled for millions of dollars just in 2011. We look at the housing where the original POAs, many of us may live in neighborhoods where you have a POA or HOA, you got to pay those fees. They tell you what you can and cannot do with your own house. Well, those were originally, I live in one of those neighborhoods, those were originally created to actually keep Black people out. And so the neighborhood association would come up with the law that said, would come up with rules that came with your mortgage that said, you are not allowed to sell this house to a Black person. And in order to live in this neighborhood, you have to sign that agreement. So that's where those originally came from. So redlining specifically was created to keep Black home ownership and minority home ownership down, and has successfully done that throughout the years. We look at segregation. So we think a lot about the 1960s and segregation with, separate bathrooms and water fountains and that type of thing. But segregation is much deeper than that and still exists. There are areas of Little Rock here that are predominantly white, areas of Little Rock that are predominantly Black. But where did that come from? Well, it came because back in the early 1900s, here in Little Rock, there was a successful business district called 12th Street District. It was booming practices, Black businesses, Black artisans, physicians, lawyers, doctors, all the things had successful practices, and there were stores and markets and everything. The government decided that that was a good time to build 630. And so what they decided to do was build 630 right in the midst of that district. As a result, we have the 12th Street District that we see now, which is impoverished. It has underperforming schools. It has no money. This is not just a practice that happened in Little Rock. This is a practice that happened in every major city across the United States of America. In our education system, so you look at schools, there are underperforming schools, there are well-performing schools. If you look at the statistics, underperforming schools tend to be in minority areas. Overperforming schools or higher performing schools tend to be in non-minority areas. And voting restrictions, there were specific laws, poll taxes, all of those things that were put into place to ensure that minorities were not able to vote. If you're not able to vote, you're not able to put people in office that support your needs, that help to advocate for you and what you need. And so that was yet another way of keeping people in line. And then veterans benefits. Back after World War II, there were Black people and white people that served our country in World War II. Everyone came back and we had this great GI Bill that was part of the New Deal. It was a wonderful thing where our veterans could get education for free, they could get training for free, they could go and get home loans and mortgages at low rates. Vets at the end of when the original GI Bill ended in July of 1956, we showed that the education rates were up, training rates were up. There were more than 4.3 million home loans worth over $33 billion that were administered during that time. Out of that, less than 10% were allowed for Black people due to redlining that we've already talked about, due to other restrictions as far as entrance into colleges and entrance into training programs. Black veterans disproportionately were unable to participate in these things. As a result, the wealth gap, specifically from the GI Bill, almost nearly doubled during that time. We look at wealth disparity. When we look at wealth gap, here in the United States of America, as of 2021, the median household income or the median household wealth level in a white household is $187,300. When you look at Black households, it's $14,100. When you look at Hispanic households, it is $31,700. And when you look at Asian households, it's $206,400, which is not statistically different from the white households. So the wealth gap is in full effect today, and it is in effect as a result of all of these things that we've talked about. And then you can look at travel and Green Book. For those of you who aren't familiar with that concept, back in the day, there used to be what were called sundown towns, which were areas that minorities should not be after sundown because it would be dangerous. And so as a result, we weren't allowed to travel to certain places and areas. And so the Green Book was created specifically to basically serve as a map so that you could see what areas you could stop for food, areas you can stop for gas, areas you can stop and rest safely. But that limited the exposure and the ability for Blacks to travel to certain areas. So this has been in effect in our country, and it's an integral part of our country's framework and fabric. And so that's a type of racism that we have to think about. The third major type of racism that we have to think about is implicit bias. And what this is are the subconscious things that we don't really think about, but they shape our worldview. So implicit bias racism was first really defined after a Harvard Law School study. They did a study where they took Black and white little girls, 8 and 9 years old. They set them in a room and they gave them a doll. They were identical dolls. One was a Black doll, one was a white doll. They then began to use different words, and the kids were instructed to raise the doll that you associated with these words. And anytime they'd have a positive word, if they'd say smart or kind or sweet or good, they'd always associate that with the white doll, both the Black and the white children. Anytime negative words were given, criminal or evil or mean or anything like that, they'd associate that with the Black doll. And what we realized from that study is that there are certain things that we are just taught, not necessarily verbally, but by what's going on around us. And so it's important to recognize what your implicit biases are, because if you're conscious of them, you can make conscious efforts to overcome them. This is the reason why there's a lot of issues with that within the police force. This is a reason why there's a lot of issues within our healthcare system as well, because we have these natural implicit biases and it impacts the way we provide care for people. And so if you're interested, Harvard does have you can Google Harvard implicit bias test. This is the website. They look at things not only about race, but disability, skin tone, gender, sexuality. There's lots of different things. I've recently taken some myself. I personally have an implicit bias. I tend to prefer lighter skinned people and white skinned people. That's an implicit bias I have. What that means is that I have to, whenever I'm dealing with this situation or hear something, I have to take a step back, think about it, make sure that I'm not looking at it from a biased manner before I move forward. And so I encourage everyone to do the same. So how do we dismantle racism? We've talked about the 3 different types of racism. What do we do about this? There are 3 main steps to dismantling racism. The first step is truth telling, and that's really what we're focusing on today. We need to know the facts. We need to sit down, look at what has happened so that we can do better in the future. The second thing that we have to do is self-correction. And the third thing, which we aren't going to really talk about today, are reparations and community correction. So let's talk about the extent of racism in the state of Arkansas. When we look at Arkansas, from the founding of the state, back when we were a territory, the indigenous people were being pushed out. There were lots of, the Trail of Tears that came through Arkansas. Initially, these lands were actually promised to our Native American families, but illegally, the early settlers broke many of those treaties that were made and pushed them further west into Oklahoma. And so our history starts there. We've already discussed some about the enslaved Africans and the slave trade that took place. When we look at our Latin American migrants, this has happened at 2 major points in history. Back post-World War I and post-World War II, there was a labor shortage throughout the country. And so it was encouraged, Latin Americans were encouraged to come from both Central America, South America. They're encouraged to come to work in our agricultural fields and coal and mining. But when they came here, they were able to work, but they were discriminated against. They were treated like Black people. So there were signs up, no Mexicans allowed, no Hispanics allowed here. If they were able to come into restaurants, they had to sit in the area that was segregated for only the Black people. And most of the time, at this time in history, they would come, they would work, and then they'd return back to their home countries. There's been a second wave that's occurred since the early 2000s. And since that time, there have been lots of reports of discrimination towards these groups. In fact, there was a study that was produced called Operation Intercept, where they looked at Little Rock School District, and they interviewed kids from about 5 different schools there and asked them questions just about how they were treated, looking at race relations. And what they found is that at a disproportionate rate, our Hispanic children were sexually harassed, physically harassed, bullied, intimidated, and had violence performed against them at a significantly higher rate than any other group. And this was happening as young as 4th grade. When this was brought to the attention of the Little Rock School District, they acted like they didn't hear about it. And so the data was brought again and again, and it took about 1.5 years and some media involvement before it was ever acknowledged that it was happening. And that's right here, just 10 years ago that this was happening. And these cases are still prevalent today. And so when we look at our Japanese Americans in World War II, for those of you who are not aware, back after Pearl Harbor occurred, there was a big hysteria. There was this concern that the Japanese were going to infiltrate America. And as a result, over 120,000 Japanese Americans were sent to what they were called war relocation camps. There were 2 that were located right here in Arkansas, down in Rower and Jerome in Deshay County. And they were essentially internment camps. They contained schools, an open area, hospital administration buildings, living areas, but had community bathrooms, community laundry rooms, kitchens, dining halls. They were surrounded by 8 watchtowers and barbed wire and monitored by military police. So these were open from 1942 to 1945 and contained about 8,500 Japanese Americans that were kept here during that time frame. 168 of them experienced death in these internment camps right here in Arkansas. Think about our Southeast Asian friends. So back in 1975, after the Vietnam War, there was a huge push for refugees, or a huge group of refugees that came over, and they went over to Fort Chappie outside of Fort Smith. There were Vietnamese, Laotian, Cambodian, Hmong, a whole non-homogeneous group of people that were brought over. Over 52,000 refugees were processed through that area in just a year's time frame. They were met with very mixed emotions. Some people were welcoming, others, as you can imagine, were not. And as a result, as they were processed through, the vast majority of them quickly left Arkansas because they did not feel very welcomed. We've already talked about Black Americans and the Jim Crow laws that existed. We look at our Pacific Islanders. For those of you who are not aware, the U.S. took possession of the Marshall Islands back in 1944 and created a strategic military weapons base. And so from 1946 until 1958, the United States government detonated 67 nuclear bomb tests over the Marshall Islands. This led to, of course, exposure and deadly radiation. And so what the government did by 1978, the Marshall Islands had declared independence. And then from there, there was a compact of free association with the United States government that was signed in 1986. What this did was that allowed Marshallese people to freely come to the United States without having to worry about passports and visas and that type of thing. The problem is that they were allowed in the United States, they were allowed to come and work, but we did not provide any type of access to our US political system. We did not allow any access to our US political resources. And so even unless they had children that were born here, they had no access to insurance or any other social programs to help them. And so the biggest population of Marshallese people outside of the Marshall Islands is actually here in Arkansas, with more than half of them living up in Springdale area. And so with the Affordable Care Act, many of the Marshallese people were finally allowed to have some access to healthcare. And in 2017, Marshallese children did become eligible for Medicaid. So if they were not born in the United States, they could have some access to Medicaid. And in last year, our government did allow for adults that were eligible to Medicaid that were Marshallese to gain access. But that has literally been in the last 4 years after the history that we've had with them. When we look at Islamic people, post 9/11, there were tons of reports of mosques being defaced and of people being harassed just on the streets, not allowed in businesses because they looked Muslim and because people were afraid of them. And then Chinese during the pandemic, which really makes no sense. But there were tons of news stories where they talked about people that may not even have been of Chinese origin, but of some type of Asian origin by perception were harassed because I have no idea why. So that's the history that we have here. And so as we have talked with different people, we've gotten oral history and learned a little bit more. We've learned how some of those systemic problems have led to funding problems in healthcare. So our hospitals in the state of Arkansas were completely separated until about 1967 to 68, when the national CMS came into being. And so until then, there were Black hospitals and white hospitals. And oftentimes Blacks did not get access to healthcare. So it wasn't until the 1970s where clinics and public health organizations were really available for everyone. And so as we've spoken with different people and read different literature, famous poet Maya Angelou, who grew up in Stamps, Arkansas, told a story about how she was refused refused by a dentist to be seen for a toothache because he said he'd rather stick a hand in a dog's mouth than put his hands in a Black person's mouth. Or Dr. Roger Bose, this story was told by his widow. He was a physician down in South Arkansas who had a child that needed treatment. And there were two hospitals, as I mentioned at that time, one that admitted Black patients, one that admitted white patients. So he took the child to the hospital. The hospital was full. So he put the child in his car, took him to the ER in the white hospital, just carried him in, bust in there, grabbed supplies, gave this kid an IV. Administrators came in, the doctors came in, the nurses came in, they're yelling and screaming, this makes us look bad. You can't have him in here, that type of thing. His response was, what would you do if Jesus Christ walked in and tried to heal this child? The administrator told him, this is not about religion. So there was just a perception that Black people were being treated here, and hospital administration just did not even want that perception on them. Or Dr. Doyson Elders. She was a Secretary General here, and then she was the first Black Surgeon General, first Black Surgeon General under the Clinton administration. She tells the story about her brother Bernard, who at that time they did not have a car, and so they put him on a mule, For 12 miles, he went to see a doctor. He got really, really sick. They diagnosed him with a ruptured appendix. There was no Black hospital in this area. And so the doctor said, well, I can't do anything for you. So he puts a drain in and just sends them on their way. It's a miracle that he survived that. We know that you would need some antibiotics and surgery. He didn't get any of that care simply because of his skin color. When we've talked with different people, one common thing that's come up is the presumptions of disparity. So you're a Black person, so you must have high blood pressure, or the misperception of pain. There have been many studies that show that Black people are perceived to be more pain tolerant. And so as a result, when we have pain, it's not treated appropriately. And there are tons of studies that show that. When you look at infant mortality, there's a perceived lack of intelligence or a lack of morality that comes along with it. We talked with individuals that told us stories. One 13-year-old, when she was 13 years old, she had broken her arm, cheerleading accident, broke her arm, goes to the doctor with the broken arm, fix my arm. And she's being questioned about her sexuality and questioned about other things that are completely irrelevant to this broken arm, but they were more focused on that than fixing her problem. We heard many times that Black people felt like they needed to be dressed up when they went to the doctor. They had to dress in their Sunday's best, because if they had all appeared to be dirty or poor or uneducated, that they would be not treated properly. The ways screening for diseases occurred were all dictated due to this structural racism history. If you look at socioeconomic factors within our state, ACEs, or adverse childhood experiences, the state of Arkansas has some of the highest rates of ACEs in the country. And when you break it down by race, Black students have 2 times the rate of white students for ACEs in our region. Education is another the described area of discrepancy. We talked about it a little bit earlier, but the state of Arkansas was actually sued in federal court by the Lakeview School District because we severely underfunded in the past rural and poor school districts in our state. When you look at the judicial treatment of non-white youth versus Black youth, first off, Arkansas has the 4th highest incarceration rate in the country, and that continues down into our court system. And so Black youth are incarcerated at a 4 times higher rate than white youth, and Hispanic youth are incarcerated at a 2 times higher rate than white youth. And this is even if you adjust for the exact same crime. Black kids are much more likely to receive a longer penalty and a harsher penalty. Now, recently there have been some changes that have in the juvenile court system so that the presumption of guilt for non-white youth has been tempered, but those incarceration state rates are still very elevated. And then poverty, which is oftentimes associated with racism as well. And so as we've talked with other professionals, we've learned about recruitment and how it's difficult to recruit minorities. There's an absence of mentors, there's hazing that takes place, or there are uncomfortable situations that may come up that we don't feel comfortable commenting on because we are concerned about possible retribution. We're concerned about the possibility of being blackballed, or the possibility of being isolated, or the trajectory of our careers. There are professional organizations that specifically excluded Blacks. We talked about how the AAP did this. And so as a result, about 120 years ago in Arkansas, the Arkansas Medical Dental Pharmacy Association was created to serve as a professional organization for the interest of Black professionals in this state. That organization still exists in existence and robust, and does a lot to try to help keep the needs of the Black community at the forefront. And then the lack of research opportunities. These are examples of some microaggressions that were reported to us in our and during our interviews. One of our interviewees explained how she walked into a room and someone reported to her, well, you're just as well educated as the white people. And she was like, well, I'm actually more educated because I'm a doctor and you guys are not, but okay. Or during a grand rounds when the diagnosis was cystic sarcosis, one of the senior physicians said something to the extent of, well, we don't usually have Mexican housekeepers up here. And everyone laughed. And it's one of those situations where you look around and you're like, well, this is uncomfortable, but you can't speak up because everyone else seems to think that this is okay. Or at a morning report where a patient it said that a patient may have chitlin-associated diarrhea. And the first question is, well, was he Black? It's like, well, that's not quite appropriate. So Now that we've talked a little bit about the different types of racism, let's give some few specific examples on how the structural racism has influenced care today. So tuberculosis is the best example that we have in the state of Arkansas from a data standpoint. The Boonville Tuberculosis Sanatorium was opened back in 1910, and that is known as the Arkansas State Sanatorium. So if you ever Google tuberculosis, this is the one that's going to come up. So it was opened back in 1910. It had a very robust budget at the time, very robust maintenance budget at the time, huge facility, and it was known worldwide. It was like the gold standard, the premier place for tuberculosis treatment. A few years later, McRae was open. Much smaller budget, much smaller maintenance budget. Started off with 26 beds. More beds were slowly added, but there was a wait list out of the world for it. And this facility remained segregated. It was a Black facility. It remained segregated until 1967 when federal law forced them to integrate. So if you look at tuberculosis elimination in the country, you can see it started off way high, and we really worked. We never made it to the elimination threshold, but we kind of drove it down. But what's very interesting is if you look at the demographic information. So just to make so everyone knows, if you look at the demographic of our state is about 75% white, about 15.5% Black, about 8% Hispanic, less than 5% other. Okay. So if you think about those demographics and then look at the demographics of our tuberculosis cases, you can see that in every age group, the white tuberculosis rates are significantly lower than any other group, which if you think about where we started from, the premier treatment, the premier facilities, all of those things, it would make sense. And that's something that is started in 1910, but persists even till today. There's a persistent disparity as recently as 2020. And the numbers of individuals with tuberculosis. That's both in children as well as in adults. When we look at our COVID-19 diagnosis and admissions into the children's hospital systems throughout the state, a similar disparity is shown. Only 27% of kiddos that were admitted to the hospital were white. The rest of them were non-white. Well, why is that? Well, if you kind of think about it and look at the data, you'll see that many of these minority families lived in multi-generational homes because they weren't able to because they're not able to purchase homes secondary to the redlining history. You'll look at the types of jobs and you'll look at all of those things and see how some of those systemic and structural racism has led to these numbers. When we look at the severity of disease, we see a similar tale. When we look at the infant mortality rate, and this is the one statistic that really just hurts my heart, our infant mortality rate in the United States, of course, is worse than any other developed nation. But when you look at it in regards to race, it's even more alarming. So Black kids are twice as likely, our infant mortality rate is twice as high as that of whites. And that remains regardless of education and regardless of age. And so that to me is exceptionally alarming, and it's something that we have to address. When we look at tobacco use within youth, the Black and Hispanic youth are much more likely to use tobacco products, and we all know about the secondary effects of that. And then when we look at the incarceration rate, I mentioned this earlier, but the rate of incarceration for minorities is much, much higher than that of whites. And so what do we do about this, right? So we've talked about it. Now, what do we do about it? I don't have all the answers, but there are a few things that we can kind of talk about. The first thing is that semantics matter. So it's important that we do not use race as a proxy for poverty or poverty as a proxy for race. We should recognize that scientists and researchers will often conflate race and class under the assumption that all Black people are poor and all poor people are Black. And that is something that we have to stop doing. We need to avoid race pathologization. That is the practice of attributing poor health outcomes to an individual race rather than to the socio-political factors that influence those outcomes, and perpetuating the false ideas that health disparities are due to biological differences. We need to recognize that the burden of disease affects certain racial groups more than others, and we need to acknowledge the roles of the institutional and structural racism in fueling those health inequities while we're identifying those disparities. We need to recognize that race is a social construct and that racism has had devastating impacts on people of color, And we need to focus not only on genetics and biology, but on the experience of racism and on social drivers of health inequities, not just race when we're describing risk factors for disease. So we can look at what some other institutions are doing. In UCLA, they've created this health equity dashboard where they are using it to detect variations in in patients' healthcare and looking at quality outcomes. And by collecting this data, they're able to figure out ways to mitigate those outcomes. Massachusetts General has created this patient reporting outcomes measure where they are utilizing demographic data that is provided by the patient. So we aren't just looking and making assumptions. We're allowing the patient to say what their demographics are, and then and then they're able to create outcome measures based off of that. Penn Medicine has created a platform called Lift Every Voice, which allows for anonymous reports of racism or inequities. Oftentimes, we have found in our research that Black people are afraid to, or minorities are afraid to speak up when something happens because, again, they don't want to be pigeonholed, they don't want to be labeled. And so this system will allow for the problem to be seen, to be addressed, to be acknowledged, taking the emphasis off of the individual that's doing the reporting. And then Boston University School of Medicine has created a longitudinal training curriculum that has been integrated throughout the medical school training that's talking about health inequities, the history of racism and structural racism. They're including that within their actual medical school curriculum to try to prevent some of these biases from being taught. And what can you do as an individual? So each of us should consider the wounds of racism in our country. And we need to recognize that looking at history from other minority groups and poets and leaders from other minority groups should be studied and it should be acknowledged. We need to make a list of resolutions and promises and vows that we can use our power and privilege and platforms to help uplift minority leaders. We should recognize that it is a challenge for Black and Brown people to speak their truths about racism. And we should stop talking about how uncomfortable it is to talk about it. It's uncomfortable. This is an uncomfortable talk for me to give. And I know it's uncomfortable sometimes to hear, but we have to look within. I have implicit biases. It's important for me to recognize that so that I can look at the facts, I can change what I'm doing. It's important to be willing to stop talking and to listen to what needs to be done. We should spend some time intentionally with people that are different from us. And then intentionally ask your patients or others that you interact with, ask them about themselves. We all have some type of common ground. And so step outside of your comfort zone, try to get to know someone. And finally, hold yourself accountable and hold others accountable. Not just kind of, I'm going to share this article or I'm going to do this, but really and truly look within yourself, be a measured voice that can help cause change. And so here are a couple of references, and I'd love to have a rest of the time for discussion to talk about what you guys are seeing and what you're doing and how we can make this better for everyone.
That was really incredible. And also, I think incredibly brave because you're right. It's an uncomfortable topic. And I think we're all uncomfortable. And I always like to think of at the end of every encounter, I always say, I need a bow on it. I need a bow on it. That's how I like to end every encounter. It's like, I feel good about it. Hopefully they feel good about it. But this topic doesn't make any of us feel very good. So hopefully it opens a conversation, a thought process, but I think we have a lot of work to do. So we have to keep that in mind. Does anybody have anything that they want to ask? Okay. Here.
So that was wonderful. One question I have for these organizations like the universities you mentioned, even our own, where we now have courses that we all have to take on implicit bias, et cetera. Has there any data been published to see, does it do any good? I know it's a good place to start, but is the way we're doing it effective, and are we measuring the effectiveness of these programs? I guess that's the real question.
Absolutely. So it's honestly only been in the last handful of years that this has become a thing, and that many institutions are starting to implement them, and they're implementing them with the data collection. And so what I mentioned before about the patient-reported outcome measures, and with UCLA's diversity dashboard, they are actually collecting data on that and utilizing that data to make sure that it's worth something, but impact change. So yes, there's data collection that's going along with it for sure.
So one question I have is about building trust with our patients and families. I've heard from our social workers at Arkansas Children's that there is a level of distrust amongst the African-American community in Little Rock, specifically with medical providers. And clearly the history gives them reason to not trust medical providers, but just trying to build those bridges back. You gave some good thoughts about how to start doing that, but do you have any recommendations like in those one-on-one encounters of trying to build trust?
I think that the most important thing is to recognize the history, and to recognize that it may be uncomfortable, but try to treat them the way you would treat any patient. One of the biggest reports that we've gotten in our research is that Black families will oftentimes feel talked down to, or will feel like they aren't being listened to properly. So they will say their complaint and then it will be overlooked. And so really making sure that you are taking what's being said and repeating it back to them, making sure that you understand what they're saying and don't discount or don't push it aside. And again, thinking about your own implicit biases and making sure that you take a step back and say, okay, if I was told this by my friend over here about her child, how would I respond? And make sure those responses are the same.
So I was just gonna say, awesome, very awesome. It is definitely difficult to get up there and talk about this subject. And I noticed my friend here, we were both kind of, moving in our chairs, like when you talked about certain stories, because we've heard those stories, we know those facts. But also, and I don't know who this is in front of me, but another thing that would be important, I would think, 'cause on the social worker side of things, is meet them where they're at. A lot of it is just listening to your patients. I say that because even when I went to a cardiologist and, I'm educated, I have my master's. And when I told them that I've had a history of heart disease in my family in the 30s, they literally looked at me and they were like, yeah, you're not a smoker, you're okay. But I was like, no, I want these tests because I know. And so I feel like just listening to your patient and listening to what they're saying, that's a big step. It really is. They'll get you far. Because that's all I wanted my doctor to do. I was like, I just really need you to do this test so I can be at ease. But awesome presentation. I loved it.
I think I got the mic. So thank you so much. That was great. One of the things that you hear a lot about race blindness or not paying attention to race. And we may one day be there, but not yet. I mean, in fact, in order to address implicit bias, it requires consciousness of that, because otherwise you're right back in the unconscious bias. So again, great talk. Thank you so much.
Hey, my turn. That was so awesome, Gwen. I can't tell you, I'm just sitting here and learning so much for a person who hasn't grown up in this country, and having learned all this through experience as an educator here and as a physician here. All this put together is now, I get it. I get it. So thank you so much for that. The other comment I wanted to make was, I think we have to start this very early in life education in schools, in colleges. So I think it's very important for us to change our education system a little bit. So also for us to talk about this in a positive way in our homes. My daughter is taking US history right now, and I've learned so much from her. And so I think it has to start from very early in life, as well as I know there is a big effort in the medical school here to integrate this. And because I teach the PharmD course, I know we are integrating these things into our courses, into our cases. I also feel that the USMLE questions should take the race out of their questions as well, because that's how we are taught in medical school, right? So I think I also want to put a plug for the SEED training here at UAMS. The SEED training is where I learned about the redlining and about the green book and all of those kind of things. So that's also a great avenue for us who are at UAMS to learn about DEI. And so great talk. Thank you so much.
I wanted to make a couple of comments about how the